That's great. to.
Welcome to our event here. I'm Dr. Elaine Murato, the founding dean of the Parkinson School of Health Sciences and Public Health. And today we are reimagining innovation, improving health equity, and building resiliency, and hosting our inaugural innovation challenge with our partners at Lyfebulb. You know, events like COVID-19, which is the theme of our innovation for this year, have dramatically shown us the effects of suboptimal health systems in our country. The inefficiencies and unevenness in access to care, and the continued health disparities that we've observed with COVID-19. And we're called to address the longstanding disparities in upstream determinants of health, which include things like racism, poverty, and education that affect our downstream determinants of health and outcomes. We at the Parkinson School, as a Jesuit institution, believe very strongly in the World Health Organization's statement that the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being, without distinction of race, religion, political belief, economic, or social condition. And yet, moving health innovation forward really requires an entrepreneurial spirit and team effort, because we operate in a health ecosystem that is highly fragmented. And so it really requires that entrepreneurial mindset. And with that, we're really delighted to be partnering with Lyfebulb in this challenge this year. And so I'm going to turn it over right now to Dr. Karin Hamburger.
Thank you, Elaine, and thank you to Loyola University of Chicago, and especially the Parkinson School for partnering with us on this this event and this effort. We're excited to be co-hosting this innovation challenge focused on how COVID-19 and any real pandemic, a big crisis, has driven entrepreneurship and changed the way that we can impact public health, health inequity, and healthcare delivery. It is often through crises that we can come out stronger. And what we are looking at here today are 11 strong entrepreneurs who, through their lived experience, through their companies, and also their personal experiences, have come up with solutions that address these very issues. Today we are excited to be listening to their pitches that will be assessed and questioned, and hopefully with constructive criticism from our very respected and experienced jury. And so Lyfebulb is an organization that focuses on that specific lived experience. We focus on innovation, we focus on education, and we believe that education, innovation, and connectivity drive empowerment of patients and, of course, people, because patients are people. Connectivity is important for us, and that is reflected by our recent entry into the digital health space, where we have built our first patient platform in the area of organ transplant, and soon we'll be launching our second digital platform in the area of inflammatory bowel disease. So as a company, though, we have always been focused on solving problems. As you live with a chronic disease, or if you're going through a crisis from a public health perspective, at Lyfebulb, we think about the next steps. We think about how to thrive, how to live through more than just survive. And that's where innovators such as these finalists really show their incredible spirit. So with that, I am going to move very quickly through our introductions, and of course, just talk a little bit about what this event is going to be about. So first, I'll introduce our very experienced jury, who all come from different backgrounds, diverse educational backgrounds, and also their capabilities are really meant to be here today to ask questions that continue to push our entrepreneurs so that they can develop further. So I'd like to introduce them first here in the order of appearance. Lisa Hienberger, who is an associate professor at the Department of Strategy and General Management, but also the director, importantly, of the Entrepreneurship Institute that focuses on social impact, which is very much part of what we're looking for today. Of course, the financial sustainability of the companies are important in any innovation challenge focused on business, but the social impact and what the overall impact is on the people who are experiencing these conditions is what we're looking for here as well. John Ponsol, who is managing director at Havas Health and You, the largest marketing and advertising agency focused on healthcare in the world, will be here really to push our entrepreneurs when it comes to their commercial thinking. How is this going to be sustainable? How is this going to make money eventually? Because otherwise we can't continue to work, very much part of any public health effort, and especially in the COVID crisis, where we saw reflected that those who really were hit by the COVID pandemic, came from backgrounds where they just didn't have the access that they deserve. Dr. Abigail Silva, who is an assistant professor with the Department of Public Health Sciences at the Parkinson School, is not only going to be a judge, but also one of our inspirational speakers that I'll talk to next. And she's very experienced in the area of epidemiology and public health, so brings that hat to this picture. Finally, Jeffrey Yang, experienced digital health person with a background in computer science and engineering, who is the chief technology officer of Lyfebulb, is really responsible for building that team and has done so in several companies in the past, including 2 recent startups that have come very far in both their financing and their service toward patients. So if we go to the next slide, I want to introduce our very important guest speakers who will bring some variety to these pitches. And we will start with Abigail Silva, who will talk about a more systemic approach to dealing with public health issues, and will be reflected by a case in the Chicagoland area. And then our own Lyfebulb ambassador, Daniel Garza, who represents more of the grassroots efforts and talking about his perspective as someone who is going through a tremendous amount of issues based on inequities in the system, and of course also living with a number of different chronic health issues, but always being incredibly inspirational. And I hope you will enjoy both of these talks. Now moving to our finalists, the most important people of today's event, and they will each be pitching for 10 minutes, and they will have 5 minutes for questions by the jury. And they range, as you see here, and from when it comes to age, gender, diversity approach, and you will see that there's a variety of solutions to these problems. It's going to be a tough day for our judges. We hope it's going to be an inspirational day for all of you in the audience. And we hope above all that there will be many synergies that will be observed so that our entrepreneurs will continue to be stimulated, and will work with several of maybe individuals at the university, individuals from the investment community, and from the corporate community, so that we can see some of these solutions be scaled and to be addressing the problems that we very much need to solve. So with that, I'm going to move to our guest speaker and give the floor to Dr. Abigail Silva.
Oh, thank you so much for that. Thank you for that introduction and the opportunity really to say a few words this morning. Of course, I want to congratulate our finalists, and again, thank the Lyfebulb team for partnering with us to bring this innovation challenge to fruition. It's been a really exciting process, and I'm thrilled to be a part of it. So innovation, as you all know, is really an imperative, right? It's a requirement for stimulating growth and for creating positive change. And especially as as Karen and Elaine pointed out, especially during crises, right? In fact, crises are favorable and opportune moments to innovate. And in fact, the discovery of new vaccines, drugs, and the development of medical techniques are just some of the tools that have arisen during the times that we've been managing health crises, especially epidemics or pandemics. So according to Everett Rogers, who put forth the diffusion of innovation theory, an innovation is an idea, knowledge, technology, a product, policy, or even a practice that's perceived as new to the individual or the adoptee, right? Whether it's a person or an entity. So I am one of the co-leaders of CIRCLE, which stands for the COVID Equity Response Collaborative at Loyola. And like the innovations that we'll hear about today, CIRCLE was born out of a need to meet a gap in the community. Our health sciences campus is situated in Maywood, Illinois, which is a western suburb of Chicago. And it's predominantly African-American with a growing Latinx population. And like many Black and Brown communities across the country, Maywood was hard hit by the pandemic, early and hard. And in fact, early on in the pandemic, one of its leaders reached out to Dr. Amy Luke, who's our public health sciences professor and chair of the department, but also a longtime resident of Maywood with a long history of engagement in the community. So they reached out to her because there was no COVID testing in the community and they wanted to change that. Now, for those of you who don't know, testing is a powerful tool when we're trying to fight epidemics, because it allows us to isolate those who are infected, right? And quarantine those that are exposed, thereby helping to thwart the transmission, right? So what followed then was the creation of CIRCLE, which was an innovation for us, because for us, it was a new practice that entailed creating interprofessional collaborations and partnerships within our university. We engaged School of Nursing, School of Medicine, School of Law, School of Social Work, and collectively, we funneled resources and creativity to bring together free testing in the community. It's a new practice for us that entailed working with the local public health departments to offer resources and support to the communities, so to empower them to help mitigate the negative effects of the pandemic. It's an innovation because it's a new practice to us to engage and work alongside community members, leaders, and organizations to collectively help meet the needs of the community so that no one is left behind. So through community engagement and partnership building, we have pivoted from increasing access to testing earlier in the pandemic to now increasing access to vaccination. And CIRCLE is not only helping to fill a gap in health and social needs in the community, it's actually also helping to fill in the gap in trust, right? Our Black and Brown communities do not easily trust a system that has consistently left them behind. This includes academia and the healthcare system. It includes the private sector and the public sector. And as was pointed out by Corinne and Elaine, the current pandemic highlighted for all of us to see the gross health inequities that exist globally and in the United States, which is one of the richest countries in the world, right? And the thing is that public health practitioners and health equity researchers were not surprised. Why? Because we know that the vast majority of health outcomes are influenced by what we call the social determinants of health. That includes the socioeconomic factors, the physical environment, the built environment, and healthcare access and healthcare quality. Now, it's important to understand that these social determinants are the circumstances that are shaped by the distribution of money, power, and resources at the global, national, and local levels. We live in a world and in a system that consistently provides more opportunities and resources to some populations while leaving others behind. And they're consistently the same populations, right? So the innovations you create, and I want you to consider this, the innovations you create are in part driven by the desire to fill in the gaps in opportunities and resources, right? And I applaud this, and the passion that you bring is inspiring. However, I also want you to consider that your innovation has been created to fit into a system that is unjust and unequitable for many people, right? For instance, if your innovation is available through employers, this means it's only available to those that are employed. If it's available through the private insurance market, it is then only available to those that are privately insured. If your innovation is pilot tested in a small community of users with smartphones, strong Wi-Fi access, a medical home, will your innovation be accessible to those who might benefit the most from your innovation? So as you create your innovations, I urge you to do so using a health equity lens. So what does that mean? Well, it means that you ensure that the needs of the vulnerable individuals and communities are being considered when you plan your tools and your approaches. And as innovators, you are in positions of privilege and power. And as the saying goes, with great privilege comes great responsibility. So let's help chip away at a system that is heavily stacked against the most vulnerable, to disrupt that status quo. And yes, your innovations have the capacity to improve the health and lives of many. But if you use a health equity lens, your innovations can dramatically improve the lives of the most vulnerable, and in the process, reduce inequities, not exacerbate them. Let's all recognize that our country, our community cannot achieve its full potential unless all its members can lead their healthiest lives. Let's build a more equitable environment so when the next pandemic hits our community as a whole, collectively, we are able to combat it more swiftly and effectively. Thank you.
Thank you so much, Dr. Silva. We will now invite Dr. Catherine Grill, representing NILF, as the first innovator to pitch her company.
Hi, I'm Dr. Catherine Grill, the CEO and co-founder of NEO. At NEO, we're providing personalized mental health support to teens and young adults. There's a mental health crisis in our country, and our teens are especially affected. The majority feel an overwhelming pressure to succeed that comes from school, peers, and social media. Since COVID, there's been a sharp increase in adolescent suicidal ideation that urgently needs to be addressed. There's also limited access to care. There are not enough school counselors to meet the demand for appointments, which means wait times has been up to 60 days. We need an innovative solution that addresses teen and young adult mental health. And that's where NEOF comes in. We've built a self-guided digital platform and mobile app that allows for clinical integration with schools and healthcare organizations. We're changing the way healthcare is delivered, using technology to provide immediate access to care. Our self-guided solution is scalable and highly affordable, which is increasing health equity. And we're also addressing this public health crisis by reducing teen stress and supporting their mental health. The way NEOF works is teens complete our personalization survey when they first sign up. It just takes a few minutes, and we use this information to identify their health needs. Our proprietary algorithm takes this information and matches teens with content personalized for them. They engage with self-guided activities directly on our platform, like relaxation practices made by real doctors and clinicians. We have practices like guided imagery, art therapy, breathing, journaling, and more. That's all created and owned by the company. NEOF also has clinician-led videos for these teens to watch. We have healthcare professionals that work as content creators for the company, who make new video series every month to educate about different topics in mental health. These videos span topics like drugs and alcohol, LGBTQ+ mental health, managing academic stress, and more. We even have peer stories videos where students who work at the company make vlogs about their lived experiences in mental health. These videos are so powerful because we use them to decrease stigma and encourage teens to reach out for help if they're struggling. NEOF has live stream community events where we bring together clinicians, teens, and more for discussions around mental health. And we're also starting to add instructor-led movement classes. Teens can track their progress directly on NEOF to see how they're doing over time, and we use these progress information to update their personalized care plan and the content that we match them with. Beyond this progress tracking, these skill building activities, videos, and community events, we also have health analytics that we can use to let stakeholders know how their students or patients are doing. This includes aggregate de-identified information, for example, about a student body, where we can send real-time updates. And we also allow healthcare professionals to choose individual students or patients to monitor. If that person gives consent, they can share real-time health updates with their provider. NEOF has a crisis care referral system as well. We've built a proprietary natural language processing system that looks for text data on our application. If anything is picked up that's indicative of suicide, self-harm, or depression, we can make a real-time crisis referral. Whether that's to a text or hotline, a school, or a clinician, we can customize that referral. We're especially proud of this feature because it's life-saving and addressing the emerging effect of COVID, which is that increase in adolescent suicidal ideation. We take a B2B approach, selling NEOF to schools and healthcare organizations who pay an upfront annual price per teen to access this service. We're currently working with high schools, universities, and healthcare organizations like health insurance. We're a new company, but growing fast, and we just crossed the six-figure mark in revenue. Part of the reason we're growing so fast is because of the huge amount of support that we've received from young people. In 2020, we had 700 inbound requests from students who wanted to work at our company. We established an ambassador program where students help us with product development, sharing this program with peers and their school, and overall growing our community. This ambassador program has scaled organically to 176 school chapters in the past 12 months. NEOF is different than other products on the market. We have proprietary precision neuroscience algorithm that personalizes content. We also have a proprietary NLP system that makes real-time crisis care referral. Everything we've done has been co-developed for teens and is specific to their needs, which is different than programs that were developed for adults on the market. We have a growing community of passionate student ambassadors. We have the most self-guided techniques to offer. And beyond those techniques for resiliency and skill building, we also provide community through our ambassador program, live stream events, and our student blogs, which is key for engagement. NEOF has the broadest clinical application as well. We can be used for general wellness and stress management, as well as support for 40 different healthcare conditions. I have a background in clinical care and clinical research, specializing in adolescent and young adult mental health. My co-founder, Lucas, studied business and has a master's degree in engineering. He's been working in management at technical companies. Florian is a serial entrepreneur with a previous exit to Siemens, and Dr. Wheeler is both a medical doctor and clinical psychologist with 40 years of experience in the field. Everything we've done at NEOF has been co-developed in partnership with more than 250 youth, which is a huge reason that we're seeing engagement in our product. We're having an immediate impact on these students' lives. By using technology to change the way healthcare is delivered, we can reduce wait times that students and teens are currently facing, now allowing them to get immediate access to care through our program. We're also increasing health equity by supporting some of our most vulnerable students. More than 50% of our user base identifies as BIPOC. When we talk to these students, we've asked them how they use NEOF. And we've heard that it's helping them overcome some cultural barriers like stigma, where they can become comfortable about mental health and use this program as a stepping stone to reach out for support from teachers, counselors, or other adults in their community. Everything I've discussed is currently developed, live, and on the market. We have real teens using this program, and they're highly engaged. They're currently spending more time every week on NEOF than people spend on leading mindfulness apps. We're also seeing clinically significant decreases in stress as measured by the PSS-4, which means NEOF is having a real impact on their mental health. Over the past 12 months, we've conducted a lot of focus groups with young people to really understand their needs and how to build this program for them. We found that community is important to them, as well as peer support, because it helps engage them and break down stigma. That's why, if awarded this grant funding, we would use it to add a peer support feature to NEOF, matching teens and placing them into moderated chat support groups based on interest and area of need. We've already started some focus groups with our young people and will continue to do so over the next couple of months. The plan is to pilot our peer support group in the beginning of 2022 and then go live later in the year. NEOF has raised a pre-seed funding round with notable investors earlier this year. We're on track to raise seed funding by the end of the year, and we'll use that to continue to grow our company. At NEOF, we're on a mission to make sure every single one of the 40 million teens and young adults in America has access to stress and mental health support whenever and wherever they need it. We're using technology to change the way healthcare is delivered, providing immediate access to care. We're making things scalable and affordable, increasing health equity. And we're also addressing this public health crisis by supporting youth mental health. Thank you so much for your time, and I look forward to answering your questions.
Thank you, Catherine. I invite the jury to ask questions. Dr. Raju?
Yeah, good. Dr. Bill, thank you for this presentation. It's been pretty impressive. So for this to work, you wanted the focus is for the people to self-identify that they have a mental issue and then self-enroll, right? And also they're able to recognize a crisis by themselves and seek your help, right? Is that the way it works?
No, actually, the way that this works is typically it's coming from the school, so it can be either prescribed by a healthcare provider, like a school counselor, or we're actually seeing at the K-12 level that it's integrated into the curriculum. So the teachers are bringing it into the classroom as a tier 1 support service. So general stress and mental health support. The majority of the students on our platform, especially given their age, they don't have an identified mental health issue, about 60%. 40% do, so we do want to take that into consideration. If they know they have a diagnosis, they can report it, and our algorithm will personalize content around that. But they don't need to have a health condition to use our platform, and they're typically prompted by a teacher or a healthcare provider to sign up. Similarly with the crisis, they don't need to know that they're in a crisis state. We have an NLP, so a natural language processing system, that will look through text data, for example, their journaling entries on the platform, and can identify in real time text that's indicative of depression, suicidal ideation, or self-harm. And then we will have a pop-up come up on their screen and let them know, we think that they're struggling, and here are some ways that they can get some free support, and we will make that crisis care referral for them. So we are doing that identification, and we are nudging them to get that support.
Thank you.
Thank you.
May I go?
Yes, please, just go.
Okay, great. I do have a question. How are our students maintaining their anonymity, right? So, you have your whole, my kid's school is like really large, right? I mean, I can imagine that she might want all her peers, when she does some of the peer mentoring, right? Or group chats or whatever it is, to be among her actual peers. How do you prevent that from happening?
Are you talking about specifically the peer support that we're looking to add, or the current version of the app?
The current version and then the peer support.
So with the current version, it's completely anonymous. The student will sign up. They can use it as an app version or also as a browser version on their computer. Their data is only for them. It's not being shared unless they've provided consent to then share that data back with a healthcare professional or parent or teacher or somebody else. On the peer support version, we've actually been piloting that for over a year because we have this ambassador program. It's scaled to almost 200 schools, and we've been able to connect students throughout the pandemic virtually around areas that they're interested in. For example, body positivity, immigrant and first generation students, those are two of our subgroups that have been very active. So the students who are wanting to engage in those groups are currently opting into it, and then they're participating in that peer support group. As we're going to migrate that to the platform, so currently we've been doing that through Google Meets, and we've been doing that through Slack and email, but we want to start migrating it to the app. We are going to leave that option for students to be able to opt in. We're able to guarantee that they are students because if they're our ambassadors, they've actually gone through an interview process. Or if they're coming from our schools will give us a list of the student emails that are verified. These students are there, and we're able to ensure that the people who are accessing that feature are only students from our schools. And then we're able to separate them out by age as well, just to make sure that it's age matched and it's appropriate. So it's a feature that students can then opt into, and for the time being, we're actually thinking about keeping that feature anonymous based on these co-development sessions that we've been having with our youth.
Is there time for another question?
Yes, please. Absolutely, Lisa. Go ahead.
Okay, so I'm wondering about your social impact. So how would you see sort of your main impact, and both in terms of scale and depth?
Yeah, absolutely. So our main vision is really to shift mental health care, especially in the schools and for youth, from a model that's reactive. You know, right now, a lot of schools are waiting until there is a crisis, there is a suicide event to get students access to care, to something that is proactive. The same way that we have math, science, even gym class as kind of mandated in the schools, we're starting to see a push from the Department of Education to integrate mental health into the curriculum, to have mental health classes for students, which is very, very exciting to see. So our real main impact is to start to normalize mental health and to shift this model from reactive to a preventative model of care where all the students are getting what the schools call this tier 1 general wellness and mental health support before a crisis occurs. I know you asked yesterday too around, our impact of being able to save lives through the suicide prevention. And of course, if things are progressing as we'd like, that's going to help bring down the suicide rates, having these preventative models of care. And at some point, perhaps we don't need the crisis referral. But at this point in time, with the emerging effect of COVID-19, Mental Health America actually put out a report and showed that 51%, so more than half of teens, they looked at ages 11 through 17, were experiencing suicidal ideation. So at this point in time, we know that the crisis care escalation and identification is needed, which is why we've built it and integrated that into the product. So at this point in time, we're also looking at how many students we can then identify who are in crisis and then refer back to their school practitioner or to their mental health provider.
Thank you. Thank you so much, Dr. Grill.
Thank you.
We got to move on to Mihir Shah with UE Life Sciences.
Hi, my name is Mihir Shah. I'm the founder and CEO of UE Life Sciences, a growth stage women's health company that's making early detection of cancer accessible and equitable globally. Our products are non-invasive, radiation-free, ultra-portable devices and apps for use in clinics and home. Our leading product, iBreast Exam, is US FDA cleared, CE marked, and clinically validated by multiple independent studies and has successfully pre-screened over 450,000 women. Global commercialization is underway in collaboration with world-renowned partners with high-margin recurring revenue model in a multi-billion-dollar global market. And we are honored to receive the recognitions from the World Health Organization, the ACOG, and many others. So here's the massive challenge. Every minute that passes by, a woman dies of breast cancer, and another minute due to cervical cancer. 1 billion women globally have limited access to early detection of cancer. And there are a number of factors. Lack of radiology experts and capital for equipment. Also, that clinical breast exams can't be documented and tracked over time. And while we have ECG on our wrists, there are no digital health solutions to guide women to do routine breast examinations at home. And so this is why UE Life Sciences was born. We embarked on a journey to develop innovative, easy, and accessible tools that can be used in the clinic and even at home. We've reached here after 10 years of R&D, engineering, and product development with a diverse global team. After multiple independent clinical studies that have enrolled thousands of women, and with the support of over $1.7 million in innovation and commercialization grants. Here's iBreast Exam, a handheld wireless device that pairs with an app. It enables frontline health workers to easily find and document breast lumps virtually anywhere without pain or radiation and in just a few minutes. In clinical studies, it's been shown to find tiny lumps the size of a rice grain. iBreast Exam is US FDA cleared as a breast lesion documentation tool. I'd like to share with you clinical testimonials from few notable cancer researchers and key opinion leaders.
The iBreast Exam device is based on a principle of tactile examination. Just like your fingers have pads and feel things, this device does the same thing. It does it electronically and reproducibly. I use it in my clinic side by side with my exam to try to test the performance. And we see that in trained hands, I'm pretty good, but the device is also pretty good. And so the device has very similar characteristics to a well-trained clinical breast exam. It can be learned without being a radiologist, and it can be applied by healthcare workers. And so that really lowers the barrier to access.
Having worked with the iBreast Exam for a number of years, I'm extremely impressed by its role in clinical breast exam, and has the opportunity to provide for much more consistent use of routine annual breast examination. The iBreast Exam, unlike clinical exam, goes to the smartphone and can be saved and reproduced. It can also be accessed by experts for interpretation, and it can be compared from year to year. The iBreast Exam can be in any office, any healthcare provider, nurse practitioner, physician, rural, urban, and all women will have easy access to this inexpensive and highly predictive device.
The device can be used side by side with clinical breast exam. The beauty of it is it's going to save that result, and the next time you come back you can have a comparison. And it'll be something that goes into the electronic medical record, and the patient does arrive for the next step in screening. There's a finding, which breast it's in, what part of the breast, they know where to do the ultrasound, biopsy, whatever the next step is going to be. There's mounting clinical evidence now looking at the efficacy of iBreast Exam alongside either standard mammography, ultrasound, combinations of ultrasound and mammography, or clinical breast exam. These have been done in a lot of different countries around the globe, showing that when you use the iBreast Exam device for screening, that we can detect the women who don't need additional screening. That's been reported as a reliable and high negative predictive value. And we're very excited about it as a first-line screener for women with dense breasts, younger women.
I looked at the results of the iBreast Exam compared to the mammographic results and what we did and didn't see and the correlation. And in asymptomatic women who were coming in for screening, it was highly predictive of masses that were not palpable.
The iBreast appears to be a safe tool for use in a setting where one would be using clinical breast exam for triage. And there were no cancers that were found on clinical breast exam that were missed by iBreast. That is a very promising finding.
The iBreast Exam has the ability to change the paradigm for screening in breast cancer. That is correct.
The iBreast Exam is more likely to find smaller masses than a routine clinical examination.
This iBreast Exam makes it possible for nonprofit charities such as Rotary International to bring early detection of breast cancer to low-income communities, underserved communities, and communities that are right now below the radar in terms of healthcare. We see this as an epoch-making change in the delivery of healthcare.
If I were on the front lines in a GYN office, in a primary care office, in a low or middle income country on the front lines in a village, working out of a Jeep, I would want at least this technology in my hands to help improve the accuracy of my screening evaluation of my patients.
With this innovation, early detection can be more humane, personal, and universally accessible to everyone. iBreast exam is clinically proven and commercially scaling in multiple markets globally with a high margin, pay-per-use, razor blade revenue model. We have 8 distribution partners across South Asia, Southeast Asia, Latin America, and North Africa. We also have ongoing and upcoming new partnerships with leading pharma and medtech companies. We've sold over 750 scanners and 1.5 million scans. 450,000 women have already received a breast exam, and over 200 cases of cancer have been diagnosed with the help of iBreast exam. We are proud and privileged to collaborate with Pfizer. Under a global agreement, Pfizer and UE Life Sciences are bringing access to early detection and treatment to women in various countries. Our customers are leading health systems, ministries of health, diagnostic service providers, home health care, and primary care providers, as well as nonprofits. We've raised $4.8 million in equity capital from trailblazing angel investors and over $1.7 million in grants and awards from highly reputed institutions and foundations from around the world. We are commercializing and developing innovations that cut across multiple high CAGR market segments with solutions that are tailored for the post-pandemic world. Selfie, a connected femtech solution to manage breast health at home, track changes, and find lumps easily and objectively. Cervical, a revolutionary approach to cervical examination that will provide access to cervical health everywhere with the power of AI. Where there is an impact potential, there is certainly a business opportunity. Our product portfolio has the potential to save lives and drive value at a massive scale. I thank you for this opportunity and welcome your questions.
Thank you, Mihir.
Oh, you're welcome. Pleasure.
Anyone who wants to go first of our judges?
Yeah, I'll go first if that's okay. Congratulations on this wonderful product. It looks really fantastic and I think a game changer. But what I'm wondering is, what will you do with, if you would win this award? Because it looks like you have already won several awards and you already have funding. So what is the kind of additional value for you if you would win?
Right. So particularly for this award and this innovation challenge, our focus was to work in the communities in the United States, communities that have been affected by the pandemic, communities where women of color, especially Hispanic and Black women live and reside. There is a very high disparity when it comes to breast cancer outcomes in these populations. And we happen to know an internal medicine doctor from that's associated with Loyola College, who's been practicing medicine in that Chicago area for the last 30 years. And she's been asking me for the last 9 months to figure out a way to fund a small program where iBreast exam can reach the communities where she serves. And so I thought that that would be an apt use of funds should we win this innovation challenge.
Mr. Shah, I think, again, congratulations. It has been a wonderful product. I just want to take a look at the product is very good, but from what I understand, it looks like either it is a supplemental to a clinical breast examination, or it can be used as a substitute for a clinical breast examination. And what it's claiming is that it is as good as a clinical examination or even better than that. That's the premise of this whole presentation. Am I correct on that?
Yes, Dr. Raju.
Okay. So now the question comes in there, that simply assumes that people have gotten access to a provider for a clinical breast examination, or the people who are going to benefit by this, right? Other people who are not able to have an access to the doctor because of the insurance status, or they live in a geographically different area. So those people can only get access to your instrumentation is through massive mass breast tramps, where the people go in there and get their breast examined in various parts of the world. Is the focus of your health equity component of that?
So for underserved communities, both here in the United States and overseas, you do not need a physician in order for them to use or provide eye breast exam into the community. Mm-hmm. It is designed to be used by frontline health workers, social workers, community health workers. And even here in New Rochelle and upstate New York area, we worked with Rotary Group, where there were no doctors involved in providing this instrument and this kind of access to early detection to women. However, these organizations are connected with tertiary care centers where follow-ups, diagnostic mammograms, and biopsy type of services can be provided. So this is a new model of providing access to early detection and treatment, where the community organizers and community health support systems and nonprofits leverage the technology, identify women that need to be triaged upwards, and bring them to Westchester Medical or Montefiore or Penn Medicine, and actually get them enrolled when they would have gone missed for many months or years, and by when it's too late. So it actually absolutely advances the ball in bringing the women into care, which we know directly affects survival.
I do, I think I see its value very much at the global level, because the disparities, the inequities globally are massive, right? Especially outside of the United States, in Africa, parts of Asia. And the model that you mentioned, it makes total sense. I guess I worry about that model kind of in the United States, right? Identifying a really tiny lump, right? And then a cascade of rarely expensive diagnostic testing for a false positive, right, will just clunk up the system, right? And so that women who actually need the mammogram will have to wait months, right? And if they have an aggressive, right, breast cancer that's fast moving, fast growing, there will delay, right, access to care for those women, right? And it turns out African-American women, Latino women tend to have more aggressive cancers. So I guess I'm not quite sure how effective its use would be in a setting like the United States, given how the healthcare system is set up right now.
So several points to address there. Number one, our specificity is in the 90s. So we know for a fact, after having done 450,000 breast exams, that we don't have an alarmingly high, we have a highly acceptable false positive rate that's near where mammography is as well. Secondly, we don't compete with mammograms. So if women have access to mammograms, we are not asking those women to get an eye breast exam instead. We are positioning eye breast exam at the primary care, where there is nothing available right now besides a clinical exam. And that is if the care provider or the health worker or the social worker knows how to perform a clinical exam. And we are providing this in the community where there is no mammogram available. So in the United States, especially in situations like pandemic, about 100,000 women did not or could not receive their mammogram on a daily basis. Every day that went by, 100,000 women went without a mammogram because there was nothing available in the community or at the doctor's office. The radiology units were shut. So we could have triaged the population to identify women with a lump without really stopping anyone and only advancing the ones that actually have a legitimate lump. That's why we've done our clinical studies to show the high negative predictive value of 98%, to ensure that we are providing clinical utility at the same time providing access where none exists. Also, I'd like to highlight women that are below the age of breast cancer screening eligibility, women below 40 or 45 years of age, also do and should receive highly effective clinical breast exams, and iBreast can make that happen. It's also a test that does not have any radiation or any kind of invasive radiation. Women with dense breasts that get a mammogram, but now are told that we may miss your breast cancer because you have dense breasts. So there are a variety of areas where we can provide value in an effective and affordable way.
Thank you. Thank you so much. Okay, we're going to move to our next presenter, Dr. Jerry Wilmick with CarePredict.
Good afternoon. My name is Jerry Wilmick. I'm the Chief Business Development Officer at CarePredict. And I sincerely want to thank the judges for selecting us as a finalist for the Lyfebulb Loyola University of Chicago Innovation Challenge. Our project is entitled Digital Contact Tracing System to Keep Seniors Safe from Contagious Diseases. I've had the distinct pleasure of serving as the Chief Business Development Officer at CarePredict for a little over 3 years. Previously, I was the founder and CEO of Wiseware. We developed digital health technologies and wearables for seniors. Prior to that, I served as a program manager for the Department of Defense's SBIR program. During this period, I've also had the opportunity to serve as the co-chair for CTA's AI in Healthcare. I previously was educated at Vanderbilt University in the field of biomedical engineering. During this presentation, I will cover 4 topics. 1, I'll give you an introduction to CarePredict, an overview of our AI platform and our team. I'll then address the unmet need and the public health challenge that we sought to solve and address with our technologies here. 3, with our digital contact tracing, I'll actually demonstrate several different impacts that we've had both at a customer level and also for society at large with our peer-reviewed publications. And then finally, if we are awarded and selected as a winner and recipient of these funds, what we will do with these funds to further develop our platform and provide better care for seniors. First, CarePredict. CarePredict is an award-winning digital health company that was founded in 2013. We've received numerous awards, including AI Times Journal, Digital Health Top 150, CES 2021 Innovation Award, and most recently the Argentum Award for the best of the best technology for senior care. We have 22 issued patents to date and 2 peer-reviewed manuscripts, one of which I'll cover in more detail here. And what we're most known for at CarePredict is we developed a continuous machine observation system that consists of a wearable device, context location beacon, and an AI platform that allows us to predict when seniors are at risk for a fall, depression, UTI, all based on abrupt changes in their activities and behavior. The way the system works is the wearable is worn on the dominant arm of the senior, and it picks up changes in the kinematics of their wrist. So as they bring food, for instance, from table to mouth, it picks up their unique eating gesture. And once it's trained over a 2-week period, it can then identify deviations from the normal baseline, and that can trigger care. We are led by our fearless founder, Satish Mova, who's been in the industry for over 2 decades. He actually served on the team and was really developed the original EMR for the Palm Pilot. And he also developed several SaaS platforms for NICU, EMR, and even for home care and hospice. He previously scaled one of his last companies from 0 up to 350 customers. Our Chief Operating Officer, Greg Zobel, is a former VP of Sales and Ops from Baxter Healthcare and American Hospital Supply. And our VP of Sales, Richard Montest, has served at several healthcare companies as well, Nuance Healthcare and Med Assets. We have a rounded out team with top tier engineering, marketing, sales, and customer support talent that's helping us really bring these novel solutions to life. So what's the unmet need and public health challenge that we're addressing here today? Over the past 1.5 years during this pandemic, we've really identified that seniors, in particular seniors living in long-term care, have been disproportionately impacted by SARS-CoV-2. 0.7% of the US population is living in long-term care facilities, yet we've seen 27% of COVID deaths have been to long-term care residents. It's very sad, and what the data has shown is 1 of 12 long-term care residents actually have died of COVID in the last 1.5 years. We identified this problem and this challenge very early on in the pandemic and determined that long-term care facilities, whether it's a skilled nursing home or assisted living facility, are at a real disadvantage to maintaining and controlling the spread of SARS-CoV-2 virus due to the confined spacing and poor ventilation in long-term care communities. Recognizing this unmet need in this public health challenge. We looked at what conventional solutions were being used in long-term care to control the spread of SARS-CoV-2. And what we found is most of the solutions were really ineffective for mitigating the spread within these communities. The three main conventional solutions that we found that were being used to control the spread in these communities is one, symptom-based monitoring. So they would typically use temperature monitoring to assess if someone maybe is infected with SARS-CoV-2 before they would conduct a PCR test. The problem with this is less than a third of the COVID hospitalized patients actually had an elevated temperature. So you're actually going to miss a lot of those asymptomatic individuals. Number two, PCR testing as a conventional method. The challenge with this is it really requires serial daily testing. Early on in the pandemic, taking a lot of time to get the results of those tests back. You're missing a lot of individuals due to those time lags. And also, if a person was infected, they may be in their latent period. And so they're actually, may not show positive yet. And finally, manual contact tracing. Problem with this is it requires humans, and it's a very slow process, and actually can take days to trace an individual case. And it's incredibly error prone as well. Our solution, Pinpoint Digital Contact Tracing, actually uses our wearable device, our room location beacons, and our Pinpoint software. And what it allows you to do is it allows you to rapidly identify all close contacts and identify all potentially infected locations in that assisted living facility. And here's how it works. This is a live view. This is actually a view of our contact tracing workspace. You would go over to select the individual resident that is infected with SARS-CoV-2. You put their infection status, and then you would run a trace over a window of time. In this case, we're going from 9:15 to 9:30 for that 2-week period. And then you would just click on Analyze Contacts. And within seconds, boom, you would actually have a list of all residents and staff that individual had come in contact with during that 2-week window. So now you would know this individual had come in direct contact with these individuals and secondary contact with those individuals. You'd also know environmental contacts. So they may actually infected and contaminated certain areas throughout the community. So you could actually see those and visualize those and make sure you put your decontamination protocols into place for those rooms in particular. You also get a list of all the contacts and the duration, in fact, that they spent with those individuals. Here's a close-up look at the individual that was infected with SARS-CoV-2 and each of the individuals that they came in contact with that are at the highest priority for being tested and quarantined. We also developed a simulation tool that allowed us to compare our digital contact tracing system versus conventional tools like symptom-based mapping, manual contact tracing, and PCR testing to show how effective is our tool versus conventional methods for mitigation. And what we found with these simulations, which this publication is in JMR Public Health Surveillance, we report on the results here where we demonstrated that 52% fewer COVID cases would be observed in the community if you use digital contact tracing versus conventional methods. And also, using digital contact tracing, you could have 10% fewer fatalities per community. And the final piece is you could also reduce the number of residents that are required to be socially isolated by 66%. This impact was also observed by several of our customers, including one of our customers at Lyfebulb, where they reported that 83% of their resident populations did not require to be quarantined because they were not exposed to the infected individual. And this is critical because they could continue with communal activities, social interactions, family visitations, and have unrestricted movement. That way they didn't have to suffer the effects of social isolation and depression. We also had an impact just in terms of the general population with Reuters and Axio and New York Times articles coming out demonstrating our contact tracing tools, which were also being developed specifically for senior living. When we initially went into quarantining seniors, we found that they were suffering from social isolation and incredible loneliness during this pandemic. And research has come out that, in fact, social isolation and loneliness leads to an increased risk of dementia by 50%, an increased risk of coronary heart disease by 29%, and an increased risk of stroke by 32%. Social isolation and loneliness are incredibly damaging. So our tools not just reduce the number of cases and deaths, but also we reduced the number of residents that required being socially isolated, so they didn't have to suffer these secondary effects. We've had incredible traction to date and incredible adoption in the senior living market, which is roughly a $2 billion market, 2 million beds, and we've had over 5,000 subscribers to date. We have very strong market fit, and we keep expanding in that marketplace. If we are the recipient of these funds and this award, we will continue deploying our CarePredict system to senior living communities. And this is incredibly important because actually vaccinated seniors account for 75% of the breakthrough infection fatalities. So even though we have the vaccines, we still need tools to contain the spread, even in senior living communities. We've published an initial outcome study, which is provided here, and we've also got IRB approval to conduct a follow-up comprehensive study, which we'll use these funds to help fund. In addition, we will collect data to incorporate that new data in our system to optimize for SARS-CoV-2 variants, which we're seeing as well, and other community spread contagious infections such as C. diff, MRSA, and seasonal flu. We will also define our platform to predict other health declines beyond UTI, falls, depression. Thank you for this opportunity.
Thank you so much. Great presentation. Any questions from our jury?
Jerry, it's really a great tool to have that. For this to work, everyone, including the care providers and the visitors, has got to wear this instrumentation, right?
Excellent question. Yes, that's correct. So with our product and the customers that we have, all of the residents and the staff wear the device daily. And when visitors come, they either can have a wearable device issued to them, or they can get a visitor's badge, which has the wearable tracking system built into it. And so when they check in, it goes into our system and we know how long that person was in the building. And so if there was an incident where you have a person under investigation, you can then look at all of the individuals they came in contact with. So that's correct. Everyone that comes into the building and that works and lives in the building has a wearable device.
So the efficacy of this program, if you find the contact tracing is due to some visitor, then that makes it more difficult because that visitor, you cannot trace them after they leave the nursing home because their contact is much more different. So this works in a very confined setting with the people who are really interact on a daily basis. It will not be effective on a rotating population of places where there is a people come and go, like hospitals, where the people come in, stay for 2 days, they go away, and then new batch comes in. So that doesn't work in a system. Is that correct?
Excellent point. Yeah, so for random incidental contacts, as was proposed early on in the pandemic, when we launched our product, Apple and Google came out with some approaches to use an app from the smartphone. I think for random incidental type contacts, you would need some type of an approach like that, although there are issues and limitations of when you use a smartphone or an app. With our system, any indoor setting where you have pretty controlled access, even from outsiders, this is a highly effective. We have over 95% adherence, 24/7 daily adherence of wearing our device. So we have a pretty high level in terms of tracking all individuals in the building. But when you do have an outside individual, say from home care or from another agency that is the vector, if you have the tracing done where you know that that person brought it into the building, you could at least track where they went and who would be potentially exposed. But you're exactly right. You can't trace them once they leave the building.
Jerry, I had a question. And first of all, congratulations, a wonderful product and presentation.
Thank you.
What about the future post-COVID? Because, obviously, it sounds really like a fantastic product during the current crisis, but hopefully we will, move on eventually.
Exactly. It's a great question. Yeah. So we're, this particular tool, Pinpoint, can be used for tracking any other type of infectious diseases, including the flu, MRSA, and even C. diff. So you can actually then use these tracing tools for a variety of other types of conditions and diseases. So we're looking to expand, the platform and to fine tune for those other types of infectious diseases as well. But we're also expanding our predictive platform, which is really what this was built for initially, to predict things beyond UTI and depression and fall risk, and actually look at other chronic diseases that kind of go hand in hand with the impact of other types of infectious diseases. Great question.
Okay, well, thank you. Jerry, if I may, as the jury doesn't have any more questions, you're talking about this as an infection predictor, but could there be other chronic diseases that also could be, this could be used for in elder care, and especially thinking about the mental health component? Are there ways to maybe earlier predict events that could be very catastrophic?
Yeah, it's a great question. When I think of certain chronic conditions and even the work we've done with depression, we've noticed even during the pandemic that it was actually pretty alarming. We'd look at some of our customer profiles and just the general physical activity levels, the sleep inversion patterns we saw with the residents. They weren't eating in the community setting, as a group. They were eating by themselves in the bedrooms, and the PSQ-9, the actual depression scores were very, very high during this period, and their health was plummeting. So we were seeing that just by measuring autonomously the physical activity and behavior patterns. Even before I spoke to our customers, we were recognizing those changes. And given the importance of physical activity with variety of different chronic conditions, we can definitely have a good metric and gauge on a senior's general health based on their physical activity levels we measure with the wearable. Going forward, beyond step counts, we actually have a bunch of different scores and things that we look at physical activity levels because we're finding they're very closely correlated with the incidence of these different types of chronic diseases.
Your device could be an Aura ring for seniors.
Yes, exactly. Yeah, we actually do have, it measures blood oxygenation levels. It has two-way voice communication, automatic fall detection, heart rate. So it measures optically their heart rate. So it has a lot of those sensors built in.
Yeah.
Very quickly, who was the 5% that don't adhere to it or don't wear it? Or because you mentioned it's high, the uptake is high, but who are the?
Yeah, sometimes residents, they don't like wearing things on their wrists, and even for the memory care residents, we make special bands for them because sometimes they, like my grandfather, he suffered from Lewy body dementia, and he would pull things off his wrists. So we were finding that many of the residents would do that are in memory care. So we had a few, there's some that just don't want to wear anything on a daily basis like that. But it's a great question.
Thank you. Thank you, Jerry.
Thank you so much.
We're going to welcome Rohan Dixit with Leaf Therapeutics as our next presenter.
So I'd like to tell you a little bit more about why we're so excited about Leaf Therapeutics, our technology, and the potential of it to impact mental health. Well, that's me in the middle. And what you probably can't see from the picture is that I was suffering from anxiety and depression. And if you're somebody who has had a mental health condition yourself or have had a loved one go through this type of challenge, you know that this is an invisible illness that can often have dramatic effects on people's lives. And what I realized as I got older was that I was far from alone. There are more than 40 million Americans who have anxiety, 16 million who have depression, and 2 out of 3 of them are not receiving any treatment at all. After the pandemic, all of these trends have tragically accelerated. The CDC has estimated that now there are more than 80 million Americans who have a mental health condition, almost 1 in 3 adults in the country. And again, tens of millions are not receiving any care. Why is that? The first reason is that mental health is expensive. It's expensive for the system as a whole, $240 billion per year, now the most expensive medical condition in the country, but it's also expensive for individuals. Oftentimes, insurance does not fully cover behavioral health treatment. Patients are left to pay out of pocket, and many people in the situation where they simply can't afford care choose to forego it. The second major reason that we have such a mental health pandemic in the country is that patients aren't treated because there are a lack of providers qualified to deliver traditional mental health care to them. There are more than 10,000 patients for every one psychiatrist, for example, and many of those psychiatrists are located in urban environments. So you have wide swaths of the population who, either because of cost, because of geographic access, and in some cases because of stigma, do not seek traditional mental health care services. And the last reason that we have kind of this epidemic problem in mental health is that there aren't objective biomarkers for mental health conditions. And so clinicians are often guessing. Unlike in most other fields of medicine, where you have quantitative metrics that you can use to track when a patient is getting better or worse, that does not exist in mental health. And so with limited time with patients and limited data, the default solution is simply to prescribe medications, which oftentimes come with unfortunate side effects. So at Leaf, we looked at the situation, we really thought, how can we reimagine how mental health care is delivered? And what if there was an affordable, non-pharmacological, objective way to diagnose and treat mental health care concerns in the country? And I'm a former neuroscientist, and one of the things that we assumed in our field was that everything interesting about mental health would, of course, be in the brain. But by asking this question at Leaf and looking at really the fundamental drivers of mental health, we discovered something pretty incredible. And that was a biomarker in the heart called heart rate variability, or HRV. Heart rate variability is literally the timing differences from one heartbeat to the next. But it turns out that it has an incredible amount of emotional and mental health information stored inside. We've used some of that new research around HRV as a biomarker of mental health that has really been exciting the field in the last few years to create the world's first clinical measurement tool and treatment tool for HRV, geared towards a wide variety of mental health conditions. So the Leaf Therapeutics platform really consists of a few different parts. The patch, which is a clinical grade FDA Class 2 EKG device that combines a diagnostic biomarker, therapeutic built around that same biomarker, all of it wrapped in a telehealth delivery system so that we can reach patients where they need help. And we've managed to get this system and this technology covered by most insurance plans so that we brought the cost to $10 to $15 per month copay for most patients. So let's break some of those down. We talked about biomarkers. For 100 years in mental health, we've been looking for biomarkers to objectively track disease progression. Heart rate variability seems to be that biomarker, and Leaf has found a way to measure it at a high clinical degree of accuracy and to leverage what is almost a billion plus heartbeat data set at this point to train an AI to actually predict and detect who has a mental health condition. This is data from 900 patients where we've shown that we're able to, with a 94% accuracy rate, know who has a mental health condition, in this case anxiety, purely from biology. That, to our knowledge, is a first in the world and groundbreaking in and of itself, but we've gone beyond that. We paired this digital diagnostic with a digital treatment built around the same biomarker. And that treatment is called heart rate variability biofeedback. It has 30 years of evidence behind it. One of the inventors of the technology is an advisor of ours today. What Leaf has figured out is how to combine those two elements into a single package to create a feedback loop that has been missing in behavioral healthcare. I draw the analogy to an integrated continuous blood glucose monitor, CGM, where you're measuring blood glucose levels, and the device as the biomarker of a patient drops out of a healthy range, delivers an intervention, insulin in this case, to bring the patient back into a healthy range. We have created the CGM for mental health, wherein we can use our high accuracy sensor and AI to track this biomarker in real time. As the biomarker drops below a certain threshold, the device automatically turns on, and it uses haptics to actually guide a person through a breathing and biofeedback exercise in real time, titrated exactly to their body. And as they enter back into a physiological normal range for their biomarker, the device turns off. And that's precision medicine applied to mental health. As I mentioned, we're covered by most insurance plans. We offer both the device and the device plus coaching, both of which are covered under remote patient monitoring codes. We've shown in clinical trial data, which we published this summer, that we can decrease patients' anxiety, our first clinical indication, by 62% in just 8 weeks. That tracks with the literature on HRV treatment modalities, which show, and this is really incredible, as a researcher, when I first stumbled upon this, I was flabbergasted, that this technology, which is non-drug, which does not require someone to deliver therapy, for example, over a period of weeks and months, is actually more efficacious and has a higher effect size than either CBT or pharmaceutical drugs, which are the current frontline treatments for mental health conditions. But in our clinical trial, we went beyond just showing symptom reduction. We showed that we could improve this biomarker almost 50% in a 3-minute exercise with the device. That is data-driven mental health. We have raised a pre-seed round of $1.8 million, which is a relatively small amount of money for what we've been able to accomplish, which is to generate almost $1 million in revenue, 3,000 plus users, daily active over monthly active users of more than 20%, which is typical of a sticky app, and an NPS score, Net Promoter Score, which is a measurement of would you recommend this product to a friend, of 100, which is the highest possible score that you can get, which we're really, really honored to have received from our patients. We have built the product as a telemedicine first offering and partnered with Optum and their telepsychiatry wing in order to help us scale over the course of next year. And so we now have more than 3,500 telepsychiatrists who can help us prescribe the Leaf to patients in 35 plus states. And we have begun a pilot partnership with CVS Health Hubs, where we are launching in hundreds of their Health Hub stores across the East Coast. We have a great team, many of whom worked for many years at far below market salary, in some cases for no money at all, because they believe in this technology and they've seen the impact that it's had on patients' lives. And we believe that we have created here at Leaf a platform technology that can actually have broad efficacy across a range of mental health conditions. HRV as a biomarker tracks with anxiety, depression, PTSD, substance use. Every major mental health condition out there seems to be tied together with this one biomarker. And so we believe we have a general purpose diagnostic and therapeutic that can potentially have a TAM of 1 in 3 people in the United States. And we plan to make really our first major round of funding next year in order to help support our growth. But in the meantime, we're providing Leaf to as many patients as possible under their current insurance coverage. But of course, we would like to do more. With the grant funding from Lyfebulb Loyola, we believe that we can begin to offer Leaf to more low-income and rural patients, particularly folks who are on Medicaid, in order to expand access to mental health conditions and treatments for these conditions in the places where they're most needed. So I want to thank you for your time today. I'm looking forward to answering all of your questions. And I just wanted to end here with the simple thought of, as a mental health sufferer myself, as someone who has seen how the care system can often fail people, I really believe, and now we have a lot of great partners in the clinical and the corporate world who seem to agree. I really believe that we've created a tool that can address some of those fundamental inequities. And so grateful for this opportunity and looking forward to talking more.
Thank you, Rohan.
Thank you, Rohan. This is really exciting, and I love that it's a non-pharmaceutical intervention, right? That's really exciting. My question is twofold. One of them is, can you wean yourself off of the device over time by sort of, learning to listen to your body, basically, right? And know what you need to do. It might be too early to figure that out. And the other one is, I'm worried about stigma, right? There's still a lot of stigma in wearing a device, letting people know potentially, right, that, you have a mental health issue. Just thoughts about that.
Yeah, those are both great questions, and I think so. To the first point, we're not trying to be pharmaceutical. You have to take every day for the rest of your life. One of the beautiful things I think about empowering patients in the way that we are is that it's a skill. And after we've shown in like 8 weeks of practicing with the device that patients actually internalize the ability to be self-aware of, oh, my emotions and my body, my heart rate, these things are actually tied together. And how can I learn how to breathe to make an impact on that? So the goal really for our device is to make ourselves not needed anymore. Maybe not the best financial strategy, but I think is the best option for patients. And then to your question about stigma, that's a huge thing that we've tried to build into the Leaf, to the product from the beginning. We weren't under the clothing, right? A lot of other options, you could be on the wrist, for example. But I think for something like mental health, people want to be able to disclose that they have a mental health condition only when they choose to do so. So we've really focused on making the product invisible, unless you want it to be.
Rohit, thank you very much. It has been a phenomenally great presentation, great device. As a practitioner of yoga, I understand the biofeed mechanism. It works well, I believe in that. But I see one collateral effect on that. Purely depending on heart rate variability as a marker for anxiety or other depression, whatever it is, we'll be missing the heart rate variability really a cardiac issue, or it is really a medication overdose issue, right? Those are things we need to be careful about. People may say, okay, my heart rate variability is there because I'm having an anxiety attack, but that may be because of you really have an atrial fibrillation and you are basically going in and out of the arrhythmia of your heart, or it could be the medications are overdose. That's one of the medications is heart rate variability. So we just want to be careful about it. So I know you have a medical team around it. Have anybody suggested to you it's a good tool for anxiety, but it may also indicate other things?
Yeah, that's a great point. And this is new as a biomarker for mental health, but it's also HRV tracks with physical health conditions too. And I think what the researchers in the field, and we're collaborating with a lot of them, are coming to understand is that we've known for so many decades, right, that stress and mental health have an impact and are often comorbid with these physical health conditions, talking about heart disease, diabetes. But why is that? What is the actual mechanism for that? And I think what we're seeing is that HRV is that mind-body connection. And so I think that there's a lot more research to be done, and our device, in fairness, does pick up on arrhythmias and ectopic beats and filters those out. But I think your point is still a good one. And over time, what I wonder is if we'll be able to apply interventions like this. You talked about yoga, meditation, mindfulness, stress reduction to not just mental health conditions, but also physical health conditions, because the mind and the body are linked.
I was wondering, and actually following up on Abigail's question, in how many cases do you see that patients don't need to use it anymore? Do you have data on that? And then the other one is about the competitive landscape. So are there alternative solutions? So are others doing something similar to your solution?
Yeah, so to your first question about how well do people learn the skill? We showed in a controlled clinical trial of 8 weeks that by about the 4-week mark, the majority of patients, more than 87% of them, were able to increase their HRV through breathing. So that's kind of the core skill, right? Am I aware of how I'm feeling, and can I breathe through that to change my physiology? So I think one of the disadvantages that we have as a younger company is that we don't know what somebody looks like a year, or 2 years, or 5 years out, and that's really critical information. And hopefully we'll survive long enough to see that, and it'll be good outcomes data. So far, it looks good, but that's all I can say. To your, could you remind me, Lisa, your second question?
Yes, I was wondering about alternative solutions in the competitive landscape.
Right. So we are the only device that is on the market now that can both diagnose and can use HRV as a biomarker to diagnose and also to treat in real time. But there are other companies that have emerged that are using a similar tactic around HRV, which I think is a great thing. For example, there is Miru Health, which is run by a friend of mine, well, a colleague and an acquaintance, but a very good person, who is also using HRV in a mental health context, but using different types of technology that are a little older, a little clunkier and harder to wear. But there are other people that are starting to use HRV. Apple as well just had a new project that was leaked where they're looking at HRV and anxiety and depression. So I think it's coming.
Good. Copying is good, and competition can be very good. So thank you, Rohan. And we are going to move to our final presentation before our lunch break. And it's by Shireen Abdullah with the Yumlish.
My name is Shireen Abdullah, and I'm the founder of Yumlish. At Yumlish, we're on a mission to eradicate diet-related chronic illnesses focused on minorities and addressing socioeconomic barriers to dietary adherence. I want to introduce you to Carla. Carla is of Mexican origin. She's a grandma, works at a bakery. She gets a type 2 diabetes diagnosis, and the best advice her physician can provide to her is to, quote, eat healthy. I think we have to ask ourselves, what tools have we provided someone like Carla to, in fact, enable her to eat healthy? There's a gap in diabetes management. In that what Carla wants to know is, does insulin cause blindness? A huge misconception in the Hispanic community today. Time and again, physicians are asking their patients to stop eating tortillas and white rice. What Carla is getting are tools that are not created for someone like her. They largely take a one-size-fits-all approach, do not address nutrition in a meaningful way for her. They severely lack cultural competence. Carla's life hangs in the balance in our ability to deliver great care, and nutrition is fundamental to that care. She is not getting that today. Carla is certainly not alone. There are 6.4 million Hispanics with diabetes that are underserved and largely neglected by solutions. And though we are focused on the problem in the Hispanic community today, there is a lot of work ahead for Yumlish to focus on other groups and other disease states. So what do? We took the standard of care for diabetes prevention, diabetes management, adapted it to make it culturally relevant for someone like Carla. We paired that core value proposition with registered dietitian support, peer support, referrals to community-based organizations to address food insecurity, and device-less remote patient monitoring. The biggest takeaway here is that it is all provided over web and text. Ultimately, we created a low-cost program with low barriers to adoption. And we know that it works through the impact on outcomes, a weekly engagement rate of 73%, translating to 12.5 virtual touch points per person per week, and a 90% weekly attendance rate in our program. In fact, if we look closely into the health outcomes, we've seen a reduction of 2.26 points in A1Cs. For a person with uncontrolled diabetes, that is a 30% drop. This is an expensive disease state. And using our current revenue model of insurance reimbursable encounters alone, this is a billion-dollar market. We have additional revenue opportunities to grow via population health and managed care. In fact, talking about managed care, thinking beyond this challenge, we would like to test these additional revenue opportunities with Trinity Health ACO. Their next generation ACO provides coordinated care to patients right here at Loyola Medicine. We have incredible traction to date. We have raised $800,000 in non-dilutive funding from the CDC, the NIH, the National Institute on Disabilities, with another 2.5 million options ahead for us. We have contracts with health systems in Austin and Dallas, the American Diabetes Association, and a growing relationship with school districts in Dallas. Being an approved provider under the school district plans right here in Texas gives us access to close to 300,000 teachers and staff that would yield us $20 million in revenue potential. There are opportunities for us to scale using additional technologies and AI solutions in creating a tech-enabled service that will scale the registered dietitian's reach from 100 patients, which is the industry standard today, to 500. And we have a phenomenal team to bring us there. I have an MBA of PMP. I know how to run these projects. I've been a management consultant for a number of years. We have faculty members from Northwestern University leading our data science efforts. We have subject matter expertise in nutrition, and we have built digital health products before. Our advisors stem from Ascension Seton, the Dell Medical School, from the UNT Health Science Center, and from Texas State University. Again, we have raised funds of $800,000 from all of these different organizations, and we're getting ready to raise our 1.5 million round, essentially in our pre-seed round, to fund our growth. I want to leave you with real conversations we see from our empowered participants. Starting with the one on the left, this participant shared chocolate chip cookies, pictures of chocolate chip cookies, and said, you know, friends, sometimes I want to throw in the towel, but then I think I do not feel well when I give in. I think that fact is too good to not continue, but thank God, here we are in the fight. Even when on the road, we are presented with so many temptations, we can do it. On the right is the dreaded McDonald's picture, and this participant says, look what I have in front of me, but you have to keep persevering so as to not fall into temptation. You have to be firm. Blessings to all. I just want to close with saying that at Yumlish, we're on a mission to eradicate diet-related chronic illnesses for minorities and bridge gaps to create health equity and provide Carla the care that she deserves. Join us. Thank you.
Thank you, Shireen.
Oh, I'm on. Okay, yes. Thank you. I really appreciate it. I would love to take questions.
Sure, I could start. Very nice presentation, and you're right, and there's a complete gap, in this population, and then for this particular disease especially. Have you worked with federally qualified health centers or have plans to sort of do that? I'm just curious about that.
Yes, great question, Dr. Silva. We are working with federally qualified health centers here in the Dallas area currently. We have 2 that we're working with.
And so connection to Wi-Fi hasn't been an issue and things like that?
Did jump to say that again?
So connections to Wi-Fi and things like that haven't been an issue?
Yes. Oh, great question. So what we've seen as far as Wi-Fi and data and infrastructure are concerned, what we've noticed that a lot of the participants that we're getting, the majority of the participants that we are getting have access to Wi-Fi, smartphone data. A lot of their students went online during COVID, so they're able to navigate and figure out their way to participate virtually. Now, the challenge is still that a good 85% especially in the Hispanic community, have a smartphone, which is great. The challenge, of course, still remains in that 10 to 15% that we're trying to work through on how to provide our programming to them. We're tapping into some governmental funding to try to see how we can sort of partner with those FQHCs to try to see how to close some of those gaps. But for the large part in this population that we serve, they have comfort and access to a smartphone.
Shireen, so first of all, congratulations. It's a really wonderful initiative. And I was wondering a little bit about how to measure the impact here, because it would be interesting if you could devise some way of understanding if it's your offering that is actually making the difference. Do you have any ideas about how to do that?
Yeah, so we're doing a couple of different things with that. One, we're essentially looking at the impact that our programs create. So the shorter term for us is looking at things like weight loss, A1Cs. On one of the slides, I showed that the last pilot that we ran, we saw an A1C drop of within the 3.5-ish month period, but we saw an A1C drop of 2.26 points. Right, that's a 30% drop. That essentially takes someone from uncontrolled diabetes to controlled and even sort of in the reverse remission levels. But having said that, Dr. Handberger, what we're really seeing over a period of time is more on the qualitative side, even outside of that quantitative, right? So folks reporting things like, in terms of quality of life metrics, we're seeing things like more energy, better quality of sleep, things like that. How it really lines up for an FQHC, for instance, is really helping them understand the ROI on something like this, right? So here, the FQHCs that we've been working with, we've seen that they have HRSA and CMS requirements as far as controlling A1Cs for the general population is concerned. Well, with us bringing these numbers down, that helps us create this revenue model to say, hey, we'll help you get these better rankings through CMS, and that it helps us even create like a longer term sustainable revenue model with them as well. So it all in is qualitative and quantitative.
If I may, I'll ask a question. I'm not a judge, but you drew some comparisons with Omada and Virta, and those are very big and very successful companies, and even Livongo. And you're saying that they're not personalized, but I think they would say they are somewhat personalized because they're building up data and they're learning more about each patient, and at least in buckets of patients. What do you think? Do you think your model that is so highly personalized is scalable? That's part of it. And then I would say I think you have to be a little careful not saying that they do address the individual, because I would argue that they probably do think so.
Absolutely. No, that's a great question. And when I say that they're missing something there, is because the way I guess the question to ask here is, who is using Omada, Livongo, or Virta, or any of these, organizations and their RPM devices? The target population that we're going after is very, very different from their patient profile. Right? We're looking largely at underserved. We're in FQHCs. The Omadas of the world are not in FQHCs today, right? And so that's why our target population is very different. Also in my pitch, I emphasized that we're device-less remote patient monitoring, and I wanted to go on fast to say that because what we're trying to create is a low-cost model that is, in fact, scalable, right? In some of these other models, you see that the RPM cost is sort of built into that initial onboarding of the patient. So there's $100, $150 right there that the provider, that the employer has to pay right out the gate. For us, we don't do that. We've kept it deviceless. We've kept it text-based, which I also want to draw attention to, is to say, we're not an app, right? We're not that traditional app, open this app up, use it. We're providing our service where our patients are spending their time on their smartphones. Our patients are not tech savvy. They're not about downloading another app, on their phones, remembering the username, passwords, and all of that. We used to have an app, by the way, which we've left long behind us for that very reason. Our patients are spending time on things like text messaging, on their browsers, on WhatsApp, which is a texting platform used largely in the Hispanic community. And so that's how we're delivering care. We're truly meeting them where they are in the format that they want to be met, right? For us, it is about reducing those barriers for accessibility. So,
Great. Clearly answered my question. Thank you.
thank you.
Okay. Thank you, everyone. We're going to take a break for lunch or for whatever your time zone allows. We will be back at 1 o'clock Eastern time with our guest speaker, our second guest speaker, Daniel Garza. Thank you, everyone. So welcome back, everyone, to the second half of our Innovation Challenge, focused on public health, health inequity, and healthcare delivery in the times of COVID and beyond. We are now very happy and proud and excited to welcome our second inspirational speaker, Daniel Garza, Lyfebulb ambassador and advocate star, a person living with a number of different chronic diseases, and speaks from his perspective as well as from his experience in this field. Welcome, Daniel.
Hi, everybody. Good morning. It's still morning here in Laguna Beach, California, or good afternoon to everybody. First of all, congratulations to all of you. I was able to share and talk with some of you yesterday and get to know you a little better. So that's really exciting. And to the judges, and I'm sorry, the jury, you have a tough job to pick the winner. So here's some good vibes going your way. As we talked a little bit yesterday, and you got to know me a little bit, I'll go back and review my story so you can see where my speech today comes from. I was diagnosed with AIDS back in 2000. So I've lived it. When I was diagnosed with AIDS. I've been living with HIV for 21 years. So in the 21 years, a lot has happened, not just in medication and treatments, but in my personal life. Aside from being HIV positive, I also have been clean and sober for almost 15 years, which is actually how I came to get connected with Lyfebulb through my recovery program. I was a crackhead and an alcoholic, and I'm almost going to be 15 next year. So June 21st is my quinceañera, and I'm looking very much forward to it. So look forward to pictures and a cake. If you're in Southern California, come over and have some cake with me. Another thing that happened was cancer. I was diagnosed with anal cancer in 2015, Cinco de Mayo to be exact. And that's usually my cancer joke is I'm so Mexican, I was diagnosed on Cinco de Mayo. So perhaps there you go, folks. I also live with an ostomy. I deal with mental health, diabetes, high blood pressure, cholesterol. A lot of those things are just genetics. And but nonetheless, I'm still here, and I just turned 50 last year. I'll be 51 in about a month. So there's a lot to celebrate and a lot to be excited about. Back in March of 2020, March 18, there was a lot of plans for what the year had to bring for us. And we were all excited. I was excited about about 2020. It was like the year of vision. We were going to see everything so clearly. And then suddenly March 19th came in and COVID and everything got shut down. And here in Southern California, I am board of directors for one of the local HIV agencies, and I chair the client advisory committee. So I'm very connected to the community here in Orange County as far as the HIV community is concerned. I thought, like many of us, because we've been working on social media and internet, and we have Zoom meetings, and I've been doing Zoom since like 2017. So for me, it was very easy once we went virtual to just log in and get on a call like we are right now. I mean, we're all over the country, all in one space, and we're getting to know each other. So my thought was, it's going to be easy for everybody. Well, first of all, I don't like really driving. If you've been in California, Southern California, in LA traffic, you can spend anywhere between 2 and 6 hours in traffic a day. So for me, it was like, yes, I don't have to travel anymore. And I really thought everybody was going to be on the same page. Everybody was excited to be able to work from home and not have to travel. Then I started realizing, because I'm the chair of the client advisory committee, that not everybody had the ability to connect the way that I did. During this time also, I was doing a training for, it's a program called Building Leaders of Color, where we are taught how to connect better with our community. I went into this training thinking, I know, I'm from Mexico. Hablo español, yo entiendo, I get it. Like, I was so connected. But during this training, I realized how really not connected I was to what was happening in my community. And I was very quickly realized that the word privilege had been tossed around a lot in the last several years. And for lack of better, we usually put it on Caucasian people, white people. It's like, there's the privilege. Never thinking once that I was part of a privileged community because I'm Latino, I'm gay, I'm HIV positive, etc. During this training, I realized that because I'm educated, I'm bilingual, I'm used to being on social media. As you can tell, I don't edit. I'm very open about everything that's happened in my life. That not everybody in my community had that ability. I realized that not everybody speaks two languages, which I knew, but I kind of forgot for some reason. That not everybody is documented and has fears of being found out, being deported. That not everybody, and this one really blew my mind. I get excited for, I think for the wrong reason, but then not everybody had access to internet, and the word inequity started popping up, and I was like, how is that possible? How is it possible that in 2021 not everybody has access to the internet? Everybody has a phone, and I mean, mine's right here. Everybody grabs a phone and they can go in and they check their Facebook and we watch TikToks all day. But not everybody had access or knew how to get on Zoom. So I was very naive with the agency that I'm with. We did a Zoom video. We did 2 Zoom videos on YouTube to show people how to get on Zoom. And I thought, that's my way. I'm helping my community. Then I realized that if they don't have access to the internet, how are they going to get on YouTube on their computer? And my heart just broke, realizing that people really didn't have all the resources needed to access the services that they needed. Then as I started talking to more people, I realized that there were fears still available. There was still fear in the community. There was still shame. There was still secrets and silence being kept. And as I started to call some people that I knew in the community, because I knew they weren't getting on internet, made a phone call, text them up, I realized the number of people with HIV who lived in a household where nobody knew their status, they had not disclosed. So for them, even having internet was a challenge to access the services they needed. Because if I live in a household full of people and all of a sudden we're all home 24/7 and they're asking me to jump on a Zoom call for a support group, but I have no privacy, I'm not going to do it. If my doctor is calling me and saying, hey, let's jump on a virtual call so I can give you your blood labs, I'm not going to do it. So I started to realize also that was part of my privilege, that I'm so open about my status when other people still can't. And as a person living with HIV for 21 years, and when HIV has been around for 40 years, I thought it's really, we have to come up with something better. We have to create a way, and I'm stumped. I really don't know what that way is. A way to help people come out of that shame and stigma and silence that religion, social norms, and cultural biases has put on them. Then we have phobias. And I know I don't have a lot of time, but one other thing that I discovered along the way was how phobias are stopping some of us from accessing services. Now that we're starting to go out and be out in the world again, I suffer from agoraphobia. And although mine is in the lesser of the spectrum, where I find the tools and I've been through therapy and I can go out of the house, it still sometimes takes me about 20 minutes to just get the nerve, because like right before I have to leave the house, I have to clean the refrigerator because it's so important that I clean the fridge before I leave the house. And my phobia is yelling at me that something is going to happen. So make sure you fold the towels before you walk out. And then before I realize, I'm running out the door. And that's just my phobia kicking me out the door. I realized too that a lot of people that I knew had phobias, and that some of those phobias had started to grow while we were in the lockdown, because we gave them permission without knowing to start growing. So my mission now for 2022, because can you believe it? We're already at Thanksgiving. Next week, it's 2 weeks from now, Thanksgiving, and then Christmas, and then 2022. Like, I feel like 2021 was just like a practice year. Like we just kind of like tried all these new things to see what we could work on 2022. So one of the things that I'm learning and that I'm taking into 22 is number one, help my community, Latinos, monolingual, undocumented, how to access services without the fear of being deported, of not accessing services, of not speaking the language. My other mission is speaking more about, being more open about my phobias and putting those out there so that people can understand that it can happen to anybody. Even for somebody like me that gets online at any time, does interviews, gets on stage and does comedy or acts, but that they don't know what happens 20 minutes before I leave the house. And I think a lot of people live in that fear, and we need to pull them out and talk about it and do something about it. So I'm out of time, but I want to congratulate you all. If any of you has any ideas on how we can collaborate to make some of these things more accessible, more available, or even just talk about them, I encourage you, first of all, to reach out, collaborate, let's work together, because again, I feel like 2021 was a practice year. We all kind of, you guys created some amazing projects that we're all learning about today. And I hope next year we can all just be there, practice them. And again, thank you so much for giving me your time. Congratulations to the jury. Good luck in making a decision. And Lyfebulb, I am so grateful to be an ambassador. Thank you, folks, and we'll see you next time.
Thank you, Daniel. Thank you so much. Great, great speech, very inspirational. Now we're going to move to our next finalist, being Romy Antoine with One Stop Wellness.
Hi, I'm Romy Antoine, CEO of One Stop Wellness, a health literacy platform to empower employees to track their chronic health risks and become their own healthcare advocates. I personally understand the importance of health literacy because I was impacted. My mom, who battled stage 4 bile duct cancer for 3 years, had the traits of a burnout employee, dealing with multiple chronic illnesses. One day, she came home excited to let me know that her doctor got her a personal nurse to come to the house each day so that she wouldn't have to go back and forth to the hospital. It sounded great until I did my research and found out that she was actually placed on hospice. That fact was lost in translation. I learned that many people don't understand what their doctors are telling them, and they don't know how to explain that back to their families. Also, 70% of adults forget what was said in their doctor's appointment within 30 minutes of leaving. This leads to poor outcomes. This lack of health literacy is a major reason why so much money is being wasted in the healthcare system and why workplace wellness programs have not worked. My mom's battle inspired me to create One Stop Wellness, a tool to help employees track their chronic health risks and get the right information at the right time to discuss with their doctors. Unfortunately, cancer got the best of my mom. However, I hope that this product helps save someone's life. There's a huge problem in the workplace today. We're battling increased healthcare premiums. 4 out of 10 millennials report having at least one chronic condition, and employee engagement is an all-time low. HR directors need a tool to solve this. To put in perspective, GlobalScape, our client, a publicly traded tech company in San Antonio, had high health costs due to largely diabetic population and sedentary employees. Our app helped them to do health assessments, track health risks, and we offered on-site biometric screenings, which resulted in an employee finding out that they had AFib. This saved the company a $47,000 insurance claim. They also had 72% engagement in their program, where the industry average is only 28%, and we reduced their insurance costs by 12%. Our platform rewards employees to improve behaviors and reduce chronic illness by connecting them to health experts in real time. Employees get to do health assessments and mood check-ins where they tell us how they're doing each day. When they do a biometric screening, they simply take a picture of their lab results with their smartphone, and our app pulls in all that data and analyzes it to give them a detailed report and questions to then ask their doctor. Then they get a personalized video course specific to their health risks. The HR gets a dashboard to view company-wide population health metrics to make strategic decisions in real time. COVID caused us to shift our approach. Companies need to keep employees safe, healthy, and connected. And we learned that 94% of work from home employees are actually stressed out, and 72% of them rather learn from watching a video versus reading. And we know that 84% of all internet traffic will be video by next year. So that means in order for us to be relevant, we need to create short, easy to understand video content to make learning fun and addictive. In the last 10 months, we've been able to produce over 200 classes. Our on-demand videos feature experts in nutrition, fitness, cooking, mindfulness, and medicine. Courses are personalized to each employee's health risks, goals, and demographics, and we're able to license our content to create USA Today's employee wellness program. Also, all of our videos are 15 minutes or less, which means employees can do them on their own time and it's not a time suck. We built a COVID-19 module for employers to remain compliant as they bring people back to the workplace. They can track symptom and temperature, vaccine records, and testing. There's over 42,000 companies within our market. However, we're targeting 34% who are switching vendors looking for an all-in-one solution, also that are focused on virtual remote workers. This allowed us to get business from some of the largest competitors in the space. Research has shown that health literacy is directly correlated to healthcare utilization, but our competition has yet to focus on it. The majority has been doing a one-size-fits-all approach, but we know in wellness that never works. Our differentiator is our mood tracker, which can identify behaviors associated with burnout, discreetly guide employees to the right resources they need. Our videos are all original and create a proprietary format that ensures maximum engagement. Also, our algorithm has real-time actionable insights, and for the first time, we can correlate health literacy to chronic disease risk. We're a SaaS model with 3 streams of revenue, starting at $3 per employee per month, and each medical form that gets uploaded is additional revenue for us. If we average 750 employees per account with all revenue streams, each contract would be $50,000 per year. We've also gotten opportunities to license our video content to our competitors and insurance companies. So this is a new revenue stream. We were working on a strategy to get our first 10 customers. We're going to partner with employee benefits firms because they have the client relationships and they can reduce our sales cycle. We're currently working with USI and NFP, 2 of the largest in the US. We'll also go direct to the companies, and we plan to launch paid marketing campaigns. Last year, we had 106 users on the platform, and now we have close to 19,000. We launched our video classes for USA Today, recently started 2 pilots, and submitted a proposal for a 35,000 employee group. Here's a testimonial from GlobalScape.
With One Stop Wellness, and the experience has been very rewarding. We were able, just as of today, to offer health assessments for our employees, and we've already received several responses, and one of the things we require is the annual involvement with a doctor. And so by this process, 2 of our employees have recently found out some results that they were able to take care of. One young lady had several major illnesses going on in her body, and through this process, she was able to get help, and another person was able to take care of an AFib problem that he did not know he had. So
we've successfully used our platform to identify chronic risks and improve health literacy. Now our plan is to focus on one chronic disease, diabetes. COVID has shed a light on health disparities. We work with the San Antonio Metropolitan Health District and the Food Bank on a project to use our platform as a digital health literacy tool to reduce diabetes risks in Black adults under 40 in San Antonio. People with diabetes are more likely to have severe complications from COVID-19. These organizations haven't implemented a digital tool for this cohort yet. We plan to use the funds from this challenge to develop a culturally relevant diabetes video course and health literacy trivia content with the goal to improve health literacy by 42% and reduce chronic disease risk in 20% of the cohort in 1 year. The trivia will reinforce what's being taught in the videos and allow people to get educated in a few minutes a day. We have a great team. My background's in biology and exercise science. I've implemented on-site wellness programs for over 4 years, working directly with HR and employees to know what needs weren't being met. I interviewed over 200 HR directors and 50 benefits brokers prior to launching the product to really get insight and feedback on what features were important. Jamie's background is in marketing and data analytics. He's had multiple exits, including his data company that got sold to Yahoo. He also knows how to build partnerships and grow revenue. We also have a great team of software developers in-house, and our advisors and board members with backgrounds in HR, technology, data privacy, public health, and medicine. Our goal is to close out our pre-seed round of 600K, of which we've raised 420,000. And here's a brief timeline. So we went from the MVP in 2019 to almost closing our pre-seed round. The next goal is to build our mobile app by end of this year, and then start next year with our seed round and start hiring the right staff to grow this company. So if awarded the prize, we'll use the funds to improve our population health risk algorithm and develop culturally appropriated diabetes content for this new cohort. Thank you for your time.
Thank you, Romy.
Thank you.
Questions from our judges? Who wants to start?
I could start. Can you tell me a little bit more about the food bank clients and what you're doing there?
Yes. So last year we applied for an NIH grant. Actually, this year, I'm sorry, applied for an NIH grant to create a digital health literacy tool around diabetes. So we started to speak to the San Antonio Food Bank and the Metropolitan Health District, who have access to these cohorts of it's from 18 to 40 years old. And the reason why they're targeting that age group is because they want to start doing preventive work before it actually turns into full-blown diabetes. So they would be using our tool, our app, to provide access to that content and all the health tracking tools for that specific cohort to help them better track what they're doing and get access to clinicians, health coaches, and personalized care in a demographic that they really have little of that and low access to it. So we were planning to use them as our first cohort to see if we can identify these health risks specific to diabetes that we've done in the employer populations, and use that to create new population health data that can then fuel our algorithm in the future.
Rory, again, it's a great product. Congratulations. Very impressive on the health literacy platform. My question is, since the employers are paying for it, how is the employee's privacy protected? In other words, I don't want my employer to know that I am in a bad mood today or depressed today. And I may not want to know my boss know that, because that may be, I'm afraid for right reasons, I may be used against me when they want to look at promotion or they look at me for some other reason. So how do you prevent, in other words, it's up to me to say my employer can see my data, or you have no choice in the matter?
No, all the employee personal data is not shared with the employer or anyone else. We have reminders throughout the app, little symbols with a lock that show this data is only for you and no one else has access to it.
Okay, good.
So we're reinforcing that to them. And then on the employer side, they get aggregate reports. So they can see 20% of my population has hypertension, but they don't know exactly who that person is to really pinpoint or discriminate. And there's also, we can break it down by segments, so they can track by departments, locations, age, or gender. But if we're HIPAA compliant, so let's say there's only 5 people or less in that segment, they have to roll out into a bigger group because it's easy to identify who those 5 people are. So data privacy is really one of our main focuses. So we're ensuring that no data is being shared and we keep them on 2 separate databases.
Sure, thank you.
I can ask a follow-up question. How are you assessing that health literacy is improving?
How are we assessing it? So we start when they log into the platform. We have a brief questionnaire with a lot of the topics that we're focusing on in the video content and some of our assessments. And then we use that to create a baseline, and then start adding different quizzes throughout the time whenever they log in, they're answering some questions. So now we're tracking what they already know. And then after each video, we have a set of 2 or 3 questions to make sure they're actually watching the videos, they're retaining information from it, and then they go back and take that assessment again, and we can track the increase or reduction in health literacy. And then we know with improved health literacy, for example, an employee would know whether or not they should go to urgent care or the emergency room instead of wasting the company extra money when they could have gone to a much cheaper care provider.
Romy, thank you for the presentation. I think it was really clear today. And I'm wondering, and I'm actually quite impressed about how you are looking at impact. You also had a theory of change, with impact objectives and activities that are linked to that. So that was really nice. I'm wondering, now that you're talking about all the data that you're collecting, how are you making that data actionable in your organization? So that, for example, if you notice that there are specific videos that are especially useful, or if there are any types of activities that you have noticed have more impact than others, how are you changing your model accordingly?
That's a good question. So in addition to impact, we're also a B Corp, so a public benefit corporation with that social impact goal. But when we're collecting all the data within our app, specifically the videos, we have a rating system at the end of each video. So the employees go in, they'll rate the videos based on if they like the instructor, if they like the content, is the video loading properly. So now we can track what's the most popular videos, the least popular videos, which content is being watched the most. And using all that data, we can start to filter out what isn't really performing the best and then create new content to make sure it's meeting the needs of that organization. So for example, if we're getting the biometric screenings and we notice in Q2 of this year, 40% of the employees have diabetes, maybe we should start producing more diabetes content to really help the company. So it's all personalized to the employee as well as the employer. And we can do that in real time. That's really what separates us from our competitors, because they wait until the end of the year to show that report, whereas we have reports on demand and we can go into a company and make those changes as they happen so that there's full engagement. And because of that, we've had 3 times industry average in engagement so far.
Great. Thank you, Romy.
Thank you
so much. Okay, we're going to move to our next finalist, being Don Vitale with Lifelinks.
Hi, I'm Don Vito. I'm CEO and co-founder of Lifelinks. I'm also one of 40 million Americans who today are providing support and care to an aging family member. My father, who is now 93 years old, and my siblings were caregivers for my mom, who suffered from dementia for over 20 years. This disease had a debilitating impact on her life and the lives of her family members. So it's this personal experience, as well as the experience I've gained during my career, that has inspired me to create Lifelinks. Lifelinks is redefining the family caregiving experience, the when, how, and from where families engage in supporting their loved ones' independence, health, and well-being. We are a platform in its truest sense, creating an ecosystem that connects the 3 dominant players in caregiving, addressing not only the needs of the consumer, the family caregiver, the family, and the elder, but also delivering valuable solutions to the providers of assistive technologies and services and the industries directly impacted by the aging tsunami. These stakeholders each have their own challenges and needs that, as you will see, are addressed by our solution. So we begin by delivering value to our end consumer. Family caregivers are really struggling. As you might imagine, COVID only helped to exacerbate the challenge and the challenges facing the long-term care industry. Between raising kids, managing a career, and geographic separation, time is not their friend. Active support is hard to come by, and while new care solutions are entering the market every day, it only serves to add to the complexity for the family. Like most emerging industries, elder care is burdened with a highly fragmented delivery system. That said, there are inherent demands residing within this market that are facing these families. The desire of the senior to age in place, now highlighted by the recent devastation posed by COVID. The fact that care is centered around primarily human interventions. The belief that caring for my loved one is an obligation and a personal responsibility. And finally, technology, while promising to play a major role in the solution, has been slow to enter into the homes of these consumers. In spite of the rapid growth in caregiving, demand is far outpacing the supply of family caregivers, as our demographic ages. So many believe the solution will rely on technology, and while it has been slow in adoption, we don't disagree. However, we do believe that tech is only part of the solution, and that ultimately caregiving will remain in large part a human endeavor. So we created a human-enabled technology platform that leverages technology as a means for expanding the capacity for quality caring human interventions. Lifelinks is comprised of a mobile application, a 24/7 member care center, and a curated vendor network. Lifelinks is a tool for the family caregiver that helps simplify and organize their caregiving efforts by directly assisting and even anticipating their needs. We designed our tool to allow for maximum flexibility and to evolve as the needs of those caregivers and the elder evolve. It's adaptable, enabling us to readily expand the offerings within our platform as we test and validate consumer demand for such solutions. We provide a single point of contact for all family members to engage in the care effort. Through our peer-reviewed provider network, we give families time to care, giving back the hours spent identifying and coordinating services. Better yet, members pay for these services through their Lifelinks account, allowing us to leverage the purchasing power of all members to ensure fair pricing and further vendor quality assurance. It's no secret that the elder care market is evolving, and the businesses engaged in this industry have their own set of challenges, which provides Lifelinks a number of opportunities. Quality and reliability varies greatly between providers, and the market is comprised primarily of small and mid-sized businesses who are geographically constrained, whose services are typically limited to providing one or two of the needed solutions, and who lack the resources necessary to develop the technology needed to become scalable. For these businesses, Lifelinks represents an opportunity to address each of these concerns. As trusted Lifelinks partners, they can leverage our brand as a good housekeeping seal of approval as consumers recognize Lifelinks' commitment to accept only the high quality, honest providers. And Lifelink is able to bundle their tech and services and deliver a comprehensive package solution to new, larger distribution opportunities, the industries that are struggling to cope with the rapid expansion of the aging demographic. Healthcare systems, insurers, corporate employers, long-term care facility operators, and others are beginning to recognize the role family caregivers play in their key initiatives to control cost and gain access into the homes of seniors and to introduce essential technologies. So who are we? Well, I'm the product of the multi-billion-dollar global assistance industry. I have held a variety of C-level positions in the US, Canada, Latin America, and South American markets for AXA Assistance, United Healthcare International, and most recently as North American president of Generali's travel and health assistance business. You would recognize my work most easily by the slogan, "Don't leave home without us," or anything, anytime, anywhere. Through 24-hour call centers located around the world, we responded to medical emergencies and a variety of other issues facing business and leisure travelers, engaging directly and coordinating services, including everything from arranging medical appointments to coordinating medical evacuations out of remote areas of the world. My brother Dave developed and managed large federal operations and was instrumental in standing up the Katrina and 9/11 victims operations. My son Don is a data scientist and has managed IT architecture development for the U.S. Air Force, Cigna, healthcare, and most recently an early stage innovation fund. Our advisory board is comprised of individuals with diverse backgrounds and expertise, all of whom are committed to our achieving our mission. Our business model is focused on B2B2C and will undoubtedly evolve over time as Lifelinks is successfully adopted by recognized brands. Revenue sources, while primarily subscription-based at the outset, will also evolve as Lifelinks is established in key channels and as transaction volumes develop on the platform. The elder care market is large and rapidly developing and in a state of flux. And we are witnessing the development of many new offerings within the market. And while dynamic, we recognize competition falling into the following categories: home companion or geriatric consulting roll-ups. Some of these leverage technologies to facilitate communication and case management. Long-term care facility operators, brick and mortar based solution of congregate living. And third, care platforms. Most are medically based, facilitating communication and advisory services surrounding coverage options and referrals to medical providers and care advisors. The current market structure and disruption provides a broad range of opportunities for Lifelinks and its investors. We believe our platform is unique. We are adaptable and relevant to the three key stakeholders in the market. We engage in active support coordination. And in this market, coordination is indeed the last mile and the greatest barrier other solutions are facing. Lifelinks itself is evolutionary in its plug and play approach, adapting quickly to stakeholders' needs by leveraging existing and developing solutions in the market. We are the true consolidation of humans and technology as a tool for family engagement. To date, our development has been bootstrapped by the founders and very deliberate in its execution. We have built and delivered our platform that provides for maximum flexibility and scalability, and we are now poised for market entry. We have built an iOS and Android application that is fully integrated with a customized CRM system. Now, the Lifelinks application is active and available on Apple and Android stores. We have executed agreements with national and regional providers, and we have recently launched a vendor co-distribution strategy along with some direct-to-market testing. We are seeking $3.5 to $4.5 million for marketing and distribution and enhancement of platform capabilities. Our approach and our team's experience and capabilities are very unique and very relevant to addressing the gap that currently exists in this dynamic market. We are confident in our ability to establish a dominant brand and to achieve our mission, positively impacting the lives of millions of those who care. Thank you.
Thank you, Don. Opening the floor for questions. Jeff?
Yes.
Don.
Oh, sorry.
Go ahead, Jeff.
Go ahead.
Okay. Hi, Don. Thank you for the presentations. It's a very interesting space. Congratulations to get to where you are. I think your business remind me a lot of multi-sided market space, and the challenge with those is creating and you becoming the trusted place for people to transact through your network. So love to hear your strategy of what trusted mean and how do you create those trusted.
Certainly trust is a major component in this business, in the elder care business. So for us, this is why we follow a B2B strategy. So we will attach ourselves to known brands out there and white label or co-brand our product alongside those channels that have already access and ready needs to be fulfilled by providing such a platform to their audience.
Dr. Raju?
Well, thank you. Don, again, great presentation, wonderful concept. Care coordination is such a vital issue for the elders. This is very relevant and timely. My question is, do you charge for every referral to a connection to another provider or to another services? Do the people pay for it? And the second thing will be, how do you select your other providers? In other words, other people who collaborate with you. Is it geography based? In other words, I want somebody in Iowa. You have a list of people who can deliver DME, durable medical equipment in Iowa. So how does it work?
Yeah, so first of all, the services that you would order on Lifelinks through the app or by contacting the member care center would be paid by you and through your Lifelinks account. So those services and the pricing that's provided by those vendors, we pre-screen. Okay, so you will receive basically a notification and alert on the app that says this is the price that for the transportation services. Do you accept? And at that point, you're pushing the button, and the arrangement is made. Secondly, in terms of vendor development, geographic coverage, and so forth, it's really a combination of things. And this is something that I'm quite familiar with in developing the Platinum Card, anything, anytime, anywhere solution. So we did not have providers of every service globally out of from the outset. What we had was core services that were offered by global and national providers that we would contract with, which we have. So we have ADT Home, we have Uber, we have Lyft, we have Peapod. We have those people under contract. When you're out in the middle of Iowa and Uber or Lyft is not available, our call center will engage immediately in identifying a vendor there, validating and vetting them, and providing them back to the user. So it's a dynamic kind of network development effort that has to take place. It's something that was built in my businesses before, where you basically have a research department that their sole purpose is to go out there and vet every vendor that's coming along.
Thank you.
Mm-hmm.
Donald, I have a question. So first of all, congratulations and great presentation. I have a sort of more fundamental question, perhaps, on the impact side. So if you think about the impact that your solution has for the caregiver, it seems quite clear, that you get peace of mind, and you're able to potentially reduce costs as well of providing these different caregiving services. But what about for the person who needs these services? Do you have any data or any idea about how that actually changes their lives? Because I'm just sort of imagining that for someone who lives far away from their loved ones, they would probably prefer the loved one to be close by and actually doing those things and having a personal connection and contact. So that is a sort of fundamental question.
Yeah, well, we know two things of the senior audience, the aging audience, and one is they want to remain independent, living in their own homes, and two is that they really want to not be a burden, okay, for their family members. I think those are the two major concerns that they have. So while they may want to have someone locally being able to provide that service, the family member and so forth, they're more apt to kind of rely on that individual, that caregiver, to coordinate and make those services happen, okay, or make the services and support occur. And again, I think we're targeting the caregiver themselves. That family caregiver is really our audience. The senior themselves, we anticipate the introduction of voice assistive technologies connected to our network to be able to allow that individual to, extend communication directly with the platform itself, both connecting to family members, but also their ability to actually order transportation services, order food into the home, and to facilitate that. We don't have that just yet. That's part of what our development and roadmap looks like in the future. But we do see that seniors are becoming more adapted to the use of technologies, albeit it's slow. But we think we can facilitate that through this platform approach.
Thank you. Great question. Okay, we're going to move to our next finalist, being Dr. Yair Saperstein with AvoMed, or AvoMD, sorry.
Hello, I'm Yair Saperstein. I'm the CEO of AvoMD. AvoMD is building virtual clinical consultants. The problem that I face as a clinician, but that's really even more of a public health crisis, is the knowledge challenge. Take COVID, take behavioral health issues, take any condition. When you're with a patient at the point of care as a clinician, the amount of medical information that you're supposed to know and incorporate is really an exponential amount that continually grows and is therefore inaccessible at the point of care. And this leads to patients getting substandard care, wasted healthcare spend, and unfortunately, medical errors. Our solution is taking this clinical evidence and bringing it into a form that's practically usable and actionable for localized care. Let me give you an example. Take depression. We partnered with Columbia Psychiatry, the expert in depression, to be able to take that clinical content and clinical knowledge and put it into the accelerated sequential antidepressant protocol. Let me click on the top of the screen at the ASAP protocol, and I'll be a primary care provider using this. My patient, I can access the medication library for them as needed. I can click on one of them and get the dosages, the side effects of the 7 essential meds in depression. Let me hit X. Or if I'm going through a visit, let's say it's the initial management. I'll click there. I can do a PHQ-9 calculator to assess severity, or just let's click mild to moderate because I have my PHQ score, and I'll assess the suicide risk. Let me say my patient is passive suicidal ideation. Let me click on that. And so I get a little note of what to do for this, followed by my initial bipolar screen. Let me ask the patient if they ever had a need for decreased sleep, but had plenty of energy. They're no, so negative bipolar screen. They're 20 years old. I get a black box warning of increased suicidality for antidepressants in patients aged 18 to 24. And then I have my step 1, sertraline or psychotherapy, with the dosages that I am supposed to give for titration of sertraline. And I can continue on. And it's not just depression or the Columbia Psychiatry pathways that we're handling. It's really the ability to improve clinical care delivery and healthcare delivery for any disease state or any clinical scenario. And the way that we handle that is by allowing for our content management system, the builder, to be a no-code platform, meaning you don't need to know any coding knowledge, any programming to be able to use it. So expert clinicians can take workflows, clinical content, algorithms, guidelines, and transform using our content management system, the builder, this into a virtual clinical consultant, meaning this take phone, desktop, EHR integration software that really helps clinicians at the point of care. So our key offerings, any content. It can be custom content for any hospital, or it can be best-in-class content, for example, the Columbia Psychiatry pathways that are available to the clinician at the point of care. Standalone or EHR integration. We really allow for healthcare delivery to be improved by either having it at the point of care with a patient, let's say on phone, iPad, Android, iOS, or really optimizing the workflow within EHR integration, allowing for content from the EHR to actually be populated and notes to be generated. We allow for clinical analytics. If a healthcare system wants to be able to see how are their providers using the guidelines, and then compare that to what are the outcomes. Do people that use guidelines give better healthcare delivery? The answer is they do. And last but not least is the marketplace. It allows for the sharing and also increased revenue of this content from one system to another system. Within our EHR capabilities, we're Smart on Fire compatible, which means that we can really speak with all EHRs. And so this is our mock-up in Epic that we're doing a pilot actually with Mount Sinai to allow for this capability. We are live in one site with Samsung Medical Center. We're doing this pilot now with Epic, and we're actually going to be integrating into more EHRs going forward as well. Our value proposition is that we're really able to improve healthcare delivery. We're able, therefore, to solve this public health crisis, and we're able to close inequity gaps because we improve clinical accuracy and standardization, meaning we increase pathway usage and allow for an improvement in diagnostic accuracy. This means that every patient is going to be getting the same standard best treatment. We also save the clinician's time. We were able to show in a randomized clinical trial that was conducted independently of us that clinicians can save time using our tool. We seamlessly integrate into the workflow. 92% of clinicians said that AvoMD was the only clinical decision support tool that they needed. We have a high clinician satisfaction score. And so, we're really able to be within the clinician's best toolbox to be able to give best care. And last but not least, we provide CME credits for eligible content modules to give the clinicians extra incentive for using us. We were founded in 2018. Since that time, we completed our builder, the no-code tool. We expanded to over 15 hospital systems, integrated into the EHR, raised over $4 million, expanded our team, and are moving onwards and upwards. We have a nice array of customers, as well as supporters and partners who we really help for supporting us in this journey and allowing us to be content partners as well as financial partners in our journey forward. We're addressing the $7 billion market known as clinical decision support. And as we sell into this market, we continually expect it to grow because of increased interoperability, meaning the systems speak with each other and to us, and the need for clinical decision support as mandated by federal regulations, which say that you have to use clinical decision support in order to provide the best care. We have clear advantages over our competition. Our competition is in two buckets: workflow optimization, for example, order sets within EHRs that try to make the workflow faster. And then those which are educational, for example, up-to-date, the reference tools that you clinicians can go to be able to read more. And we're at the nexus. We do both. We improve care while teaching clinicians. We're educational with a superior user interface and user experience that's customizable to individual hospital workflows, is mobile first and can also integrate with the EHR, and provides hospitals and clinics the ability to take their content and get revenue from selling that to others. We have the team to make it happen too. Junghoom is a professional developer, clinical informatics, as well as internal medicine board certified, and he's our CTO and our product visionary. I'm an MD and an MPH, board certified in internal medicine, affiliated with Mount Sinai, and I am the CEO. Lawrence is our COO. He has a private equity investing experience as well as an MBA from Columbia, and we have a very strong team within our content management, our sales, and our overall product team. We're AvoMD, enhance your clinical decision support and improve patient care. Thank you.
Thank you, Yair.
Thank you.
Jair, can I ask you something? What does it mean to be standalone? So if they use it just on their mobile, how is that documented then in the EHR? Is that possibility? And then how do you monitor equal use that that all the providers are using it, for example, for all of their patients?
So if it's used as a standalone, then it can still generate a note that's live just in the web version, not in the mobile version yet. And so you can actually have your medical decision-making that you can copy paste into the EHR. And then there's analytics that track who is using it, but there is no enforcing. And part of that is because, there's all this alert fatigue that physicians are ignoring, somewhere between 50 and 90% of alerts. And so rather than that, we fit into the workflow and allow for physicians to use it, but don't force them to use it.
Thank you very much. It's very, very informative, and it's a good clinical decision support tool. I'm asking you this because you are a practicing clinician. In academic practice, it's much easier to have the first and second line of drugs, which are incorporated into your clinical decision support. In other words, the asthma patient comes in, this is the first line you use. If it doesn't fail, you go to second level. But the market is showed that a large portion of doctors are working outside the healthcare delivery system. Unfortunately, the first and second line of medicines are decided by the managed care formula. In other words, the first line of medication for United Healthcare may be very different for the first line of medication for Anthem. So how do your clinical decision support system is basically what you think is the best care, but that may not be a tier 1 drug for United Healthcare. The patient have to pay more if you want to get that drug, even though your clinical decision support said this is the best drug. So how do you, that conundrum is always there. How do you manage that?
Yeah, that's the beauty of our system. So our system is fully customizable, which means that we can have the best in class content suggesting tier 1 and tier 2 drugs. But if there's a health system that really doesn't support that because of the insurance providers or because it's not on formulary, we can customize it, or they can customize it for their actual use. At the same time, there could be that educational line that says, you know, consider this, where the hospital may actually be incentivized to consider that second step. But everything's fully customizable to the actual workflow of what's happening.
Now I'm talking about private practice, an individual patient. Patient 1 comes in, United Healthcare patient. Patient 2 comes in, Anthem patient. I should be able to move between the clinical guidelines for United Healthcare Tier 1 drug to Anthem. That's what I'm approaching. In the health system, is much easier. So it's one formulary, not a problem.
Yeah, so we're actually building in some of those capabilities. We're doing a pilot with Montefiore to try to reduce readmissions. And part of that is to make sure that you give a drug which is on formulary for the patient as per their insurance. And so there's a searchable function that allows you to go by insurance level, which drug is the most appropriate given the whole circumstance. Because one of the major problems is patients are discharged on these tier 1 drugs, but then it's not covered, and then they don't get it, and they come right back. So we're countering that because of this.
Thank you.
I have a question. I'm wondering. I'm wondering. You were talking about equity in the sense that hospitals would share best practices, and it would mean that hospitals that perhaps don't have the same types of resources would actually get up to speed, through your solution. Is that, if I understood it correctly? But I'm wondering how that works in terms of competition between hospitals, because I could imagine that hospitals that have the resources and that have, research functions, in-house, they have an advantage over others. And if everyone starts sharing the best practices, how does that work then between hospitals?
So the way that we set it up is that academic institutions who are building content within the platform get added to the content library and then are able to sell that to other hospitals. That part allows for that competitive advantage. The other part of it, though, is that we actually allow for industry sponsors to allow for the distribution of other content. So for example, the American Heart Association just came out with new chest pain guidelines. And we have an industry sponsor called HeartFlow that allowed us, totally independent of the content creation that we did with the societies, but now they are allowing for the distribution to anyone to use these chest pain guidelines that are digitized. And so it allows for these best practice content modules to be employed anywhere.
Is there time for one more question?
Yeah, one more question, Jeff.
Sure. Just quickly, thank you very much for the presentation again. I think this is very interesting in terms of just-in-time education of helping clinical staff to do what they do. Have you, the question that I want to ask is, have you thought about integrating this with more of the current wave of telemedicine direct-to-consumer healthcare company? The reason I mentioned that is, in general, they have really a subset of condition that they go after, meaning that, maybe 5 to 10 the most. In general, many of them is 1 or 2. So they are very streamlined in terms of diagnosis and going through the clinical diagnosis at the time. And at the same time, they seem to have a unique challenges that is quite different than a hospital or healthcare provider as we know it with the physical locations.
Yeah, absolutely. So we're actually integrating into one tele cardiac provider to be able to digitize their 15 or so cardiac pathways, which can then be used when the provider is doing the telemedicine consult and allow them to make sure that they're doing the right thing with the patient. And I mean, I think the relevancy there from the clinician side is obvious. For the relevancy from the enterprise, the hospital, the telemedicine group also, you can really see how adding value there is obvious. And from the patient side, if you're getting the right care, and then the second part is if you can participate in that care, because we allow for shared decision-making through our process, rather than just being a simple order set that excludes the patient, you can see the value from the patient side too. So yes, we're definitely starting with telemedicine integration as well, which really folds out from all the other things that we're doing.
Thank you. Thank you so much. Okay, we're going to move to our next finalist, being Satya Elumalai with IDAR Health.
Hi, I'm Satya, founder and CEO of ADAR Health, a digital medicine company that is aimed to reimagine today's standards for chronic disease management and clinical trials. Every single one of you here listening knows someone with a chronic condition. I'm one among you struggling to manage my mom's health, but she's not alone. More than half of the US population have at least one chronic condition that requires regular monitoring of health. But today, we miss a lot of health signals, and physicians don't have the tools to actually track these patients when they are outside the hospital, which makes it very difficult for the health system to predict and effectively provide interventions. And patients also struggle to adhere to medication, which leads to lower persistence and suboptimal outcomes. What we really need is a multi-sensor biomarker approach to provide a more holistic view of an individual's health. Because many diseases share a similar symptomology, and it's often challenging to differentiate illness at a very early stage. And in most cases, it requires a doctor's appointment or an ER visit. Treatment in such cases are very limited success due to the progression or severity of the disease. At ADAR, we aim to decode the health signature that exists between individuals and across different population groups, detect the time period between the onset of an illness signature and obvious symptoms, and also differentiate the viral bacterial infection with or physiological digital biomarker signatures. Especially with COVID, which actually affects multiple organ systems, and although it shows severity or severely compromise the respiratory system, the detection and management of COVID needs additional digital biomarkers that are currently under-detected or underutilized. Enabling early detection of infection has the potential to change the trajectory of one's health. So what if we could take all these amazing devices and merge them into one to offer speed of analysis of symptoms and health status, and at a fraction of cost, and all through a single breath, which is exactly why we created MouthLab. It is a non-invasive, at-home, rapid health assessment device that measures more than 10 vital health parameters in under 60 seconds. Together, these parameters create a unique biosignature for an individual composed of multiple digital biomarkers that intelligently reflects an individual's true health. MouthLab is very simple to use. It's more like a breathalyzer, and daily after 60 seconds, the data from the device and also subjective data that the patient input using our app is sent in real time using 4G or via Bluetooth to our secure HIPAA compliant cloud, where our proprietary technology uses actionable data and key health insights to help generate new information to the physicians. This is clinically validated and patent protected. We are FDA cleared, CE mark approved, and more importantly, we are also ISO certified, MDSAP certified. Our solution is HIPAA compliant and GDPR compliant. So we completely de-risk the device and technology from a regulatory perspective. And we built a full stack enterprise platform which includes a single integrated device, a patient-facing mobile application to collect data that feeds into our analytics engine to generate prediction algorithms for providers, behavior coaches, nutritionists, and also trial managers to offer real-time surveillance and triaging of critically ill patients instantly or in real time. Through secure APIs and offerings through our trusted partners, we aim to accelerate the decentralized clinical trials and, more importantly, the digital transformation of healthcare. And we are very honored and proud to share that we got a federal contract from BARDA to help develop and validate the ADAR COVID-19 Decompensation Index study, or AIDI, a new kind of an early warning system that uses MouthLab to accurately predict or detect physiological changes early enough to allow a timely intervention for a COVID patient at risk for deterioration, thereby reducing their likelihood of going back to the hospital or severity of their illness or even death in some cases. We're currently partnering with several health systems around the country to develop this AIDI algorithm. Initially, we recruiting 100 patients to build these algorithms, and we will be validating with over 400 patients. Ultimately, once we get the data and validation, we wanted to submit to the FDA and get a clearance for our algorithms under software as a medical device clearance. This partnership is a true testament of our technology and the current market need. Let's see an example of ADAR's journey for a COVID patient. As soon as somebody is tested positive, they get a real-time evaluation using our care team, and then they create a personalized care plan. And the mouth lab is shipped overnight to the patient, and patient use their app and the device to report both subjective and objective symptoms. We also send them nudges of personalized, or nudge them with personalized messages, and analytics uses all the predictions in the changes in the health to actually recommend a physician visit if required. And we partner with several physician or telehealth providers so that they can instantly come in and provide care. And proactively engaging and empowering the providers with digital tools will help patients to avoid a costly hospitalization or an adverse event. Ultimately, we aim to improve the quality of life and satisfaction. In terms of business, we initially aim to leverage the RPM program to remotely manage patients, and with the support of health systems and physicians, we get reimbursement through the RPM codes, which we share with our partners. Ultimately, we aim to work with our channel partners like pharma to design, develop, and deliver clinically validated breath and saliva-based sensors and evidence-based digital therapeutic interventions for various chronic conditions. ADAR's technology has the capability to manage and enhance clinical and financial outcomes across multiple chronic conditions. In addition to these markets, ADAR aims to work with our diverse partners to address the global infectious disease market, which is projected to grow to over $160 billion by 2026. ADAR is at the intersection of 5 key markets, offering unique value proposition to our customers. The device and the technology is very simple to use. It's portable, it's cellular enabled, and the device also requires no accessories. It's interoperable, reimbursable, and caters to multiple conditions and age groups. ADAR's proprietary technology uses oral biomarkers through the mouth, through breath and saliva, to offer a more holistic view of an individual's health for monitoring health status, predicting disease onsets and progression, and also to measure the treatment outcomes. This isn't possible without our amazing team. We have over 50 years of combined experience in building devices and digital technologies. We also surrounded ourselves with relevant experts in a number of fields, which is incredibly domain to what we are doing. We are not alone. We have remarkable support from our global accelerators. We've been featured in various media outlets, and we have strong support for our R&D efforts. And we also surrounded ourselves with key channel partners for commercialization. Our award-winning technology is and its global recognition is a true testament of our current market need. And we previously raised $3 million for our product development, and currently we're raising $3 million for our commercialization efforts. The funding round actually will help kickstart the virtuous cycle of commercial adoption of our technology, leading to generation of recurring revenue immediately in the short term and becoming more profitable in the medium term. The aim is to utilize this award amount towards our regulatory consultant efforts to prepare the pre-submission package for our COVID algorithm submission under software as a medical device. We also aim to work with reimbursement specialists to design a reimbursement pathway for this specific technology for COVID, and also to file 2 patents and 1 trademark related to this application. We aim to provide improved health outcomes for users through precision medicine, provide smarter engagement and management tools for providers and caregivers, drug titration and treatment validation tools for biopharmaceuticals, and more importantly, cost-effective population health management solution for payers. ADAR has built a revolutionary medical device and cloud-based enterprise platform that leverages data science technologies. MouthLab paired with telemedicine will drastically reduce the burden of our healthcare system by diverting the traffic from the emergency department limiting the clinical exposure of our infected patients, effectively screen individuals at home, and deliver data for providers so that they can allocate the resources prudently. We are changing the culture of healthcare monitoring. Please join us, and thank you.
Thank you. Satya.
Thank you. Thanks for this opportunity. Very grateful to be here and presenting our solution.
Thank you so much for the presentation. It's great. I did have a question. How user-friendly is it to use this product? And especially as you're thinking about older populations, right, or people who live alone and they're older and things like that. How good is their sample, so to speak?
Oh, absolutely. It's super easy. In fact, we did over 100 patient study in partnership with AARP. I mean, this T-bar, which we added to the device, it's also something that came out of it in terms of the mouthpiece material, and then the capability to actually bite into the device or the mouthpiece. Everything was a feedback from users. I mean, we just built our first device almost 7 years ago to this version. So super easy to use. Today, my mom uses it, and I feel very happy that she could use it every day.
It's very interesting to me. So just explain to me, how does a breath analysis gives you an EKG and a blood pressure?
So basically, we also measuring biophysical measurements. So the user is holding the device. So we're collecting, like it's a single lead ECG. One of the leads is in the hand, the other one is in the lips. Like we have two. So we're collecting information from there. And also lips is a great place to collect information because unlike the skin that is outside, it's easier to reflect light inside the lips and access to mucous membrane, which is why this is just the basic, maybe 1% of what the actual potential of the device is. We're working on a lot of breath and saliva based sensors. So that's why I feel like super excited. Like we already have 6 or 7 other sensors that are coming in next year. And so what we are doing today by sending a sample of saliva to a lab, imagine that can be done in 2 years or 3 years in the 30 seconds or 60-second measurement.
Very good.
So congratulations again on this great product. I was wondering about the environmental impact of your product, because you have this plastic mouthpiece and it's disposable. So you throw it away after each time?
No, this is actually a reusable device, mouthpiece. So you can use it. I mean, we did a lot of tests. The lifetime can be like for almost a year or even more. After we did a cycle analysis with, we can just wash it under soap and water or put it into a dishwasher and still be fine. It will not impact any of the sensors. So essentially they can use it for the lifetime of the device. But we're hoping to at least send one every quarter, so that just to help them out use a new mouthpiece. And also the interesting part about this is like they already have ID sensors within the device, so you can actually also detect who's using it and then kind of differentiate everything. So yeah, so overall we're trying to make sure that we minimize the wastage to our environment as well.
Okay, great, thank you.
Hi, thank you for the presentations. I want to see anything that you ask a patient to do on a regular basis is challenging in general. If there's a benefit, meaning that they want to get better and get well, patient in general will follow through. But if this device is to keep patient healthy for long term, what is your strategy to convince people to stay on this, throughout the daily life?
Awesome. So for example, let's take my mom, right? She has 4 chronic conditions and every day she uses at least 3 or 4 different devices. But do you think she really uses it? No, because there's a challenge of putting her blood pressure cuff, and then also she was using a live cord before, so she has to hold that device. She uses a spirometer, but there's significant it lacks adherence from our perspective, which is why we want to pair one habit with another habit. This device with the charger, basically, we just designed it more like a toothbrush. So it sits right next to the toothbrush. As soon as somebody takes a measurement, the device automatically lights up so that the patient can pick it up, use his device. It's only like 30 to 45 seconds a day. That's one level of making it easier, and it's very simple to use. It's kind of idiot proof in a way. The other aspect is something that we have not publicly discussed anywhere, is the device also has communication capabilities. So for example, it can be used to actually communicate, so users can pick up the device and leave a message, or it has speakers already inside the device. So we designed it in such a way that every single day, my mom will hear my voice in my own mother tongue, so that she doesn't feel like disconnected. It's not like Alexa or something else which is going to actually talk to them. It is actually, it's not like always picking up the data or voice data. It only activates when they hold the device and pick it up. But in terms of messages, they can get messages anytime. So we provide customized messages to help them to be motivated. And we also provide feedback. Look, every day, imagine, just say, if I get a notification saying, hey, Satya, yesterday, your activity was great. Let's see what's your score is today. Like, just take a 30 seconds measurement, and then you'll see a score. And then let's see if you are getting this betterment of your health. Can be actually prevent you from going back to the hospital. So there are a lot of reinforcement messages can be put into the device, so that all they really need is this device. And that's why we also put in 4G into this device. So you don't need an app that goes into it everywhere you go. And the battery life of it is like, once you charge once, it can stay for at least a week. So basically you can carry it anywhere. Like, all you really need is like, pick it up, turn off the device, carry it with you. It comes with a pouch, so carrying travel pouch. You can carry it anywhere if it's a week-long trip. So users don't have to have the hassle of carrying an entire box wherever they go. They don't have to worry about like charging it every time that they use it. They don't have to actually turn on their phone, connect and pair to a device. We wanted to make it as simple as possible. It's like taking an electric toothbrush with you.
Thank you.
Thank you.
That's a great question, Jeff. Thank you. Thank you, Satya.
Thank you guys.
We are going to move to Tim Fitzpatrick with Icona Health.
Hi, my name is Tim Fitzpatrick, and I'm the CEO at Icona Health. 8 years ago, I was in a downward spiral as a patient in the VA system. What I didn't realize at the time was that my ability to understand my health played a greater role in my recovery than my treatment did. My low health literacy led to several surgeries, several hundreds of painful wound care treatments, and 18 months spent in isolation and recovery. We can eliminate barriers to health literacy and make health education more accessible, starting with one of the most complex, costly, and fastest growing patient populations in the country. Chances are you or someone you know is affected by low health literacy. This is a $236 billion a year problem impacting 90 million US adults. At the same time, 1 in 3 US adults is at risk of developing kidney disease, and 1 in 7 already has it. So relying on staffing increases or care model innovation alone are simply not going to solve these problems. We can solve these problems while saving practices and systems money, expanding their reach, and improving health outcomes. Every barrier to patient education starts with access and health literacy. We aim to eliminate those barriers using neurobiology, behavioral science, and data. Here's how it works. First, we do not add to clinical burden or rely on providers to make our platform work. Once a patient or family member signs up, we begin the process of establishing a baseline, building health literacy, building short and long-term memory, and then sharing that progress with care teams. We believe a patient's personal goals and motivations for learning are better guides than a preset curriculum. We are not reinventing the wheel with better content. Incremental engagement will not solve these challenges. We are delivery experts. We know how and when people need to learn. and we are building the tools and resources that will make personalized learning possible at scale. Why now and why start with kidney disease? Well, we believe that two fundamental shifts are underway that will accelerate the need for Icona. First, home dialysis will create demand for remote education and support to ensure patients transition and remain home successfully. Second, better detection and management will outpace the existing care team capacity for the demand of the number of patients who will require their support. In terms of market size, where the market equals the number of potential buyers times the price they're willing to pay to use Icona, we estimate an $8 billion market for all US adults at risk of kidney disease and a $200 million obtainable market over the next 5 years with 2.5 million users on our platform. The opportunity has become clearer after more than 300 discovery conversations with decision makers and stakeholders across kidney care settings in this year alone, from dialysis clinics and nephrology groups to population health providers and hospital-based teams. Here's what it looks like. A provider dashboard not only makes learning progress possible, but also visible at scale. Providers, medical assistants, and other members of the care team can track progress, questions, and even update the learning plan with just a few clicks, and we handle the rest. Patients also have access to their own dashboard. How patients interact with their plans and navigate these tools is what powers their journey and populates their providers' dashboards. We believe it's important that this tool be available across care settings, so patients have a longitudinal education record, whether they are learning about kidney disease for the first time in primary care, deciding on a dialysis modality, or pursuing a transplant, for example. Within our course player, we focused on making this the simplest, most optimal way for people to learn. Everything they can need is in one browser, from short lessons and check-ins to keyword and FAQ searches. Our goal is to eliminate the need for web searches and tabs and turn every ounce of effort into something productive, valuable, and measurable. We prepare a custom lesson plan for every user that includes a page a lot like this one that shows their progress. Comprehension is not the only indicator of success when it comes to learning. Anxiety, confidence, comprehension, and retention are all important, as well as a host of psychosocial measures and open-ended questions that uncover a user's motivations for learning in the first place. This full outcomes document is available to view and download anytime in both the patient and provider's dashboards. A great example of this in action is our recent launch of a health misinformation course. So far, we are seeing an average 40% increase in confidence when it comes to a user's ability to find health misinformation and information they can trust on their own after completing our course. Our business model is optimized for accessibility and designed for growth. Patients have access to a free version of the platform with basic courses and hundreds of free resources. They can also upgrade to the paid version to get unlimited access to all of our content and progress tracking. Providers can create an account, sign up as many patients as they want, and see practice level data for free. For $10 per patient, they can see patient level data, advanced tracking, and see third-party integrations. We are the only learning-focused technology and data play in this landscape. We are highly complementary to many of the players in this ecosystem, and in some cases, we play a critical role in enabling them to accomplish their business objectives. We expect to power much of this ecosystem's education as detection and management improve. Positive signs include tens of billions of dollars in investment that have flooded into this space in the last 12 months, and we expect to play a central role in powering the entire web of learning interactions to come. We have an unfair advantage in our understanding of the intersections of learning, psychology, and clinical education. We have access to the entire industry, from decision makers to the clinicians and patients who will help us grow. Our advisory board has built clinical education unicorns in our market, led EdTech product teams from Series C to Fortune 10, and are shaping the future of kidney education as we speak. Today, we know patient education is leaving behind too many Americans and causing hundreds of billions of dollars in avoidable costs. We also know that we have an opportunity to bring health literacy to millions in need and expand access in key care settings where we have validated the need for our solution. We will continue to respond to patients' evolving needs because that is what personalized learning makes possible. Together, we can confront health misinformation, reduce clinical education burden, and improve health literacy while expanding access to care. By powering the future of personalized learning in healthcare, Icona is creating a new category of knowledge awareness that will transform our understanding of what it means to learn about your health and to navigate your treatment options. Thank you for your time.
Thank you, Tim.
Thank you, Tim, for the great presentation. I do have a question. How will this program integrate into the EMR, right? Because I know, speaking from the VA system, right, to like get into the system and then have to go into another system, you know, to look at progress, sometimes it's just a barrier. So does it integrate into the EMR? Do you have plans for that?
We have plans for it, Dr. Silva. It does not currently integrate. So we just recently completed a sprint with the VA around developing an algorithm to help identify home dialysis candidates. So in the same vein of, we have this new platform and patients are learning and we're covering a lot of the education outside of the clinic setting. How can we use some of these health-related HOPE metrics? So when we talk about what are the metrics we care about for learning, HOPE kept coming up in those VA conversations especially. We do, as I said, have plans for it, but it is not currently something we rely upon to be able to serve.
Tim, it's an exciting product, and thank you I can hear the passion in your voice, how much you are involved in this. So is it available only in English, or you also have a Spanish version of this?
We do also have a Spanish version, but primarily what we built out is in English. We have resources in both languages, and we want to add more as well. But most of our pilots have been focused in English. But because our pilot partners are in Texas and Arizona, especially, and some in Los Angeles, we have developed Spanish content on the virtual reality side and on the online platform side.
Thank you for the presentations. Again, I think I can see the benefit from a provider bringing their patient in so they can help patient get to know about the disease better. I want you to talk more about how would you recruit patients without a provider being there to understand and want to be educated on a disease. And the reason that I think this is important is just another human being. I feel like I'm not interested in disease until I am, or my family or my close one are experiencing those disease, right? So how do you get them early in the funnel so that they start getting the benefit, we bring the benefit from this platform?
Thank you. I think the answer to this, we're starting to learn from since COVID. So everything I just shared has actually been built in response to COVID. And part of that trend and having those conversations through National Science Foundation's I-Corps program is we learned that patients are currently spending most of their time searching for information and answers outside the doctor's office. So we started to kind of pull on that a bit and found out search trends and why accessibility is often favored over relevancy. So people are not able to get to the doctor's office or going to the doctor's office. So we decided to focus instead on where are they currently finding information if they do have questions. So kind of the precursor step to where you're talking about describing. Our hope is we can identify some of those channels and forums where this is taking place and begin to offer this as a way to find out how we reach them before that is the case. I'm not certain, this is an empirical question, how we will get to that earlier step, but I think the first thing we have to do is go to those forums, offer this tool, and begin to see how understanding those interactions and providing a place that is trusted and shareable can provide value in the short term.
Actually, maybe a follow-up question on that. When you were saying that patients often just search the internet basically, and then they find lots of different information, and you don't really know what to trust, right? How are you planning to build trust in the consumer market? Because until you have a really recognized brand, how would I as a patient think, okay, this is really where I will find the good information?
The first step we did was partnerships with the vetted, trusted content providers. So our content, when I mentioned that we are not content experts, though we do create content, our first way of building trust in the short term is by using content that patients are already using. So one of the missing pieces of, say, a foundation that builds content for patients, they don't have interaction data. They often don't have much engagement data. They certainly don't have outcomes data. In fact, that is a barrier to some of the reimbursement that does exist in kidney disease around education. There is an outcomes assessment that's required, and it's just not being utilized because people cannot do it. So our initial step to gain trust is to use vetted content that patients are already using, and to be able to then use those same pathways to get in front of patients, to show the value of having that interaction, and to give them the choice to easily filter through the sources they might be used to and the topics that they might be looking for.
I just want to point out one engagement partner I think that would be particularly useful would be the National Kidney Foundation, right?
Absolutely.
Yeah.
Yeah, they are a current partner on some submitted grants as well.
Great.
Thank you.
Thank you, Tim, very much. And we're going to move to our final speaker, our final competitor, Dr. Kim Gandy with Play It Health.
Hello, I'm Kim Gandy, founder and CEO of Play It Health. We're a digital health company providing biometric monitoring in a home in a way that improves outcomes across the diversity of communities. So let me start by telling you a little bit about who we are and the vision that guides us. Play It Health is a group of passionate clinicians, scientists, engineers, and executives that have taken on the charge of monitoring biometrics in the home. We provide virtual care to support optimal, personalized health, and our offering is anchored in what is now called remote patient monitoring. Remote patient monitoring refers to tracking biometrics like heart rate, oxygen saturation, blood pressure, weight, and temperature in between office visits. We dreamed of creating a solution that was effective in every home and sensitive to the needs of the underserved, and we have created it. So exactly how does our RPM work? We work with clinicians and patients to determine at the outset the best device match for a given patient at a given time. We then design a solution that establishes the best connectivity model for a patient and clinician. Biometric outliers are monitored by Play It Health staff or client staff. We can work with both or combinations, and we leverage our domain experience to augment what each given clinical environment needs. But let's start with some concrete examples. In the pandemic, when patients were scared and clinicians were grasping for new ways to reach their patients, we helped clinicians catch severe bradycardia or low heart rates in a 65-year-old asthmatic grandmother, a condition that could have put her at risk for a fall or even worse. We caught low oxygen saturation and a poor heart rate response in a 55-year-old that was soon diagnosed with severe heart muscle inflammation, or what's called myocarditis. We found low oxygenation that was the result of COVID-19 in a 60-year-old grandmother that just thought she was feeling poorly because of everything that was going on. And we found a dangerously high heart rate in a 30-year-old woman in her first pregnancy who had been scared to go see her OBGYN because of COVID. So these are just some examples, but it's also important to see how this is applied at scale. At the beginning of the pandemic, we started with a core of biometric monitoring wrapped in a rich communication platform that allowed 5 methods of communication, something that allows us to reach patients where they want to be at any given time. And we bolstered this with education, surveys, and rewards. The pandemic, however, grossly exposed that clinicians needed even more than this to make RPM work. And we augmented our services accordingly to create an RPM infrastructure that would support deeper needs. We added continuous monitoring in addition to the spot checks that are normally necessary to take us to another level of care. We added a nurse call center and a monitoring service to bolster client services so that they did not have to add additional personnel when they initiated our service. We partnered with institutions in the community to develop cultural ambassadors, something that's necessary to effectively approach certain environments. And we added physician services for backup of busy clinicians that just could not add an extra minute to their day. With all of that, we emerged with some of the best long-term data in the industry. At 11.5 months into the pandemic, patients were using the platform with the recommended frequency 82% of the time. This is just unheard of engagement in the industry. As a result of our complete services, high levels of adherence, attention to detail, and commitment to clients and patients, we have improved outcomes in multiple chronic conditions. In heart failure, for example, ED visits and hospitalizations are significantly reduced, and patients have significantly improved quality of life, feeling improved and monitoring their health. In asthma, where engagement is through the roof, we report the first data where patients have improved quality of life with decreased use of inhalers. Patients love us because we give them a sense of calm for being there. We mold our solution to meet their needs rather than the other way around. And clinicians love us because we give them the ability to catch things they would otherwise never see, and because our high levels of engagement allow them to bill and keep their clinics running. There are multiple competitors out there, but where we distinguish ourselves is in the way we put everything together. Because it's not just the monitoring of the biometrics. It is monitoring the right biometrics with the frequency that makes sense to patients and clinicians in a way that works for them. We have gotten to where we are with a highly experienced team with members from the biggest players in the industry, including Duke, Stanford, MGH, Kaiser, and Healthgrades. We have seen healthcare for over 3 decades, with over 170 years of experience just on this slide. And we know how to ride the waves of change and meet patient needs. Though biometric monitoring has always been a part of our platform, we could see that coming almost a decade ago. Our world changed when Medicare announced it would pay for biometric monitoring in the home. Private payers followed, and the field is now off to the races. At a time when telehealth is slowing, RPM is just getting started and interest is increasing just as devices are improving, leading to a predicted market of $1.8 billion by 2026. We will focus in the biometric monitoring segment of virtual care, defining new use cases and paradigms and owning them with strong data, leading those fields. And with this new validated data, we are seeing large contracts that are beginning in January, a trend predicted to continue through 2022, leading to logarithmic increases in 2023 as our vision for being a demonstrated and trusted outcome leader becomes more solidified. We already have a diverse and strong set of partners over the years and have been recognized for innovation by both the American Heart Association and the American Diabetes Association. Forbes sees us as one of the women-led startups leading the future of health tech. The exit potential is distributed throughout the industry. This is a very active segment. For example, Best Buy and an EHR company just bought RPM companies in the last month. But exit or not, we are here to solidify the role of RPM in improving outcomes. And we are here to make sure these offerings reach everyone before we are going anywhere. Please come talk to us to help figure out how we can partner together. Thank you very much.
Thank you, Kim.
Great, thank you so much, Kim. I do have a question for you. You did mention there was a segment of the population, more than 10%, right, that did not actively engage, and meet those standards. Can you tell us a little bit more about who that was and why they didn't engage? Do you have insight on that?
Yeah, so when that slide that I showed with that was, as you realize, that was engagement at 11.5 months, right? And so that was a long-term engagement sort of analysis. So for the most part, and we did do a percentage analysis of those that were not engaged. For the most part, the biggest thing was people thought that they were well and that they did not need to continue to use the service in any longer. And truth be told, they were probably right. Our RPM models are such that billing continues as long as people use these devices. We have subsequently modified our rollout procedures, so we're not recommending that people stay on these things, and forever. Right, our recommendations are that they use our services and to the point where their care or the instigating problem has been identified, and then we move them to an inactive status where we can then just reactivate the system should they need the care. And that became very important in COVID, right? Because a lot of people want to get in, use the system, only pay for the devices for that period of time when they need to use them, go inactive. And then that's part of what we really want to be, is we want to be there should another episode like COVID come again. So we're kind of in the reserves. And I think one of the things that we've been proposing for some groups is that now in the year 2021, everybody should have an RPM solution, at least at their fingertips, should they need to get it active in a moment's notice. It's tough at the end of the day.
No, I have another question nobody wants to ask. How user-friendly is everything?
Yeah, it's very user-friendly, and we have a variety of different user models to accommodate the different skill sets and interests. So there is one user system where a patient does not have to use a mobile device. They do not have to use a tablet. They can just use the device that is detecting the biometric, and that's all they have to do. They do have the ability to go in and see that data if they want at any point in time in a portal, but they don't have to. And what we're finding is those patients are pretty engaged, and their engagement is very high, whether they just want to see it the minute that they get that piece of data and then they're done. But we also have model systems where they can see the data on a mobile device or on a tablet. And even our first model system that we launched 5 years ago at Duke in lung transplant in a patient population that had an average age of 65, they found it very easy to use. So we've set it up that it's a very simple model to use specifically for those reasons, because not only do we want to work with tech people that weren't tech savvy, we wanted to be able to approach people when they're ill and they really don't feel like dealing with this stuff.
Thank you for the presentations. I really like the fact that you are able to connect to many devices off the hand. I think that is an advantage. The flip side of that is now, based on my experience in working with devices, is you end up becoming the point of when something do fail and not working properly, you become the interface of help troubleshooting those issues for the patients themselves. What is your strategy to help patients self-diagnosis if there's a problem, or even addressing potential issues coming along?
That is a fabulous question because it is a huge point. So we do actually help with that technical support at this point, specifically because just as you identify, the clinicians, the clinics, the hospitals are not able to do that right now. So we do that, and we do have groups that are dedicated to that. But very important part of what you talk about is to make sure you use reliable devices and devices that are, for the most part, easy to use and that last. And so we make a big effort to only use FDA approved devices and to work with, and we have a group that's trained, and that's all they do is the technical support. And so we realize that that's a very critical sort of part of what they do. And we've been very pleased that the patients feel comfortable calling us and asking to troubleshoot those issues. Truth be told, for the most part, we have very few calls for the technical support, and the data's coming in. And so our pilots have shown us that we have picked systems that, for the most part, once we get them started, they can use and use well. But thank you for also pointing out the point about having multiple devices, because we think that's critical, because our ability to be a device, as we call it, sort of, although we're not really agnostic, there are definitely things that we believe in and things that we don't. But that's the verbiage in a device agnostic platform, is that we can piece together a variety of different devices. What we find is that even in the continuum of a patient's care, they may need different devices, and you don't want people using all these devices all the time. And it also gives us the ability that whenever a new, and let's just use the word hot device, comes on the market, we have the ability to interface with that and move that into new trials.
And I have a follow-up question on that. I'm wondering about data reliability. You know, if you have then all of these different devices and they're used by patients on, you know, in their homes, how reliable and how comparable is the data then?
Yeah, I think you bring up, I mean, these are all great questions, and they're, in all honesty, I think things that I can give you our answers, but none of these things are solved 100%, and they need to continue to be evaluated over time. And I'm going to just say that outright. But we do spend time with patients at the outset and have a lot of educational material on how to use the devices. And we also recognize one of the points that was brought up in these educational, elements by Tim and others today. We recognize that patients at the point of engagement aren't going to hear everything that you tell them. In fact, there's, I think it was Romy talking about how little patients actually hear when you first tell them, these issues. And so we also have mobile education on our devices, that little short snippets of how to use these things. But I think that over time, and we have a physician practice that has been launched to actually help educate clinicians on how to work with patients for these devices. But I think over time, that's going to be an entirely another realm of medical education on how these devices should be used appropriately in the clinical setting.
Yeah, I think I enjoyed your presentation. The general question is not about your product. This remote patient management is a very evolving field. It's also a very lucrative field. More and more people are coming into the field, come with so many devices, appliances, apps and all over the place. Where do you think Google Health will be in this RPM? Because they are seriously looking at these things from an angle, saying whatever it is. So a technical giant like that, right, who are basically coming into the market, because this is a very powerful, lucrative market. What will happen to all these smaller companies which are trying to do this in such a small way of connecting some of the instruments, 10 instruments, 20 instruments, where somebody comes in across the board and takes over the world?
Well, taking over the world is a little bit of a big one, because, as you know, the very issue that you talk about has been approached by almost every single microcosm of digital health, right? So that's been the same question, what if Apple takes this over? What if Google takes this over? In reality, if you know how those model systems work, those groups are always going to need groups like Play It Health, where we go in, we define a use case, we put the clinical and domain experience behind it to define the absolute ways those use case scenarios could be used well. Because if we first went into this space, in all honesty, in health adherence, and Google Health was one of the first ones that went after med adherence, and they failed. In all honesty, it put the field back, several years, because people were like, well, if Google couldn't do it, then who could? But in reality, it's that ability to be flexible, to be agile, to define a use case, to go in and try to understand it, to work with academic partners. That's where they're always going to need groups like us. So even though our wheelhouse, we already have defined use cases for asthma, hypertension, heart failure, and transplant, we are continuing to develop other use cases and uses of RPM in areas like chemical dependency. And again, what we saw in COVID, right? And we're still in the process of developing those for COVID. So I think there's always going to be a need for entrepreneurs like all of us that you have seen today, even when the Googles and the Apples sort of come into the marketplaces, because you've seen what they do, they acquire us, right? So we're still necessary, but yes, at some point in time, they may acquire us.
Well, that's my point. Yeah, you're right.
Great. Thank you so much. That was a great final statement there by Dr. Gandhi. Thank you. So that concludes our finalist pitch session. And I'm going to welcome now to the screen the Provost of Loyola University of Chicago and the Chief Academic Officer, Margaret Callahan, who will be joining me for some concluding remarks.
Well, thank you all so very much. I'm delighted to be with you this afternoon and to be able to connect as part of the Parkinson Innovation Challenge. I know this has been a remarkable and exciting couple of days. We founded the Parkinson School of Health Sciences and Public Health in 2018 as a space for interrelated fields to address healthcare delivery and public health disparities. The Parkinson School immediately demonstrated its value as a source of leadership, expertise, and service during the COVID-19 pandemic. It also showed its tremendous promise as a source of impact and innovation extending well beyond the current health crisis and looking to future challenges. The ongoing critical nature of that work is undisputed, and we are grateful to Dr. Karen Hengenberger and Lyfebulb for their partnership in what will become an annual innovation challenge. The Lyfebulb LUC Innovation Challenge, with its themes of reimagining innovation, improving health equity, and building resiliency, brings together specialties in the health sciences and public health and other fields to address the intersecting determinants of health and build new models of access and healing. I am deeply impressed and inspired by the projects presented by our finalists. These are the kind of creative and entrepreneurial models that will help to resource, deepen, and accelerate the work of health equity. In these projects and products, we get a glimpse of the future and how we as health professionals and as a society can better integrate structure and deliver services for better quality and greater equity. Lyfebulb's model of innovation focuses on the patient experience. That is exactly where Loyola's Jesuit model of research, inquiry, and healthcare begins. The needs of patients in all dimensions, body, mind, and spirit. Convening innovators at the Parkinson School is how we begin to bridge the gaps between patient communities and care partners to accelerate insights, build new solutions, and bring revolutionary products, treatments, and services to market. I am deeply grateful to Dean Elaine Morato of the Parkinson School of Health Sciences and Public Health and to Merle Thomas of the Center for Health Innovation and Entrepreneurship for their work and their leadership. CHI is a hub within the Parkinson School for scholars, community partners, thought leaders, entrepreneurs, and students to engage in purpose-driven research with the goal of reducing health inequities and improving healthcare delivery. The projects pitched today truly represent the future in the innovative spirit that will foster healthier individuals and communities. So well done to all of you. Finally, I want to pause in gratitude and a bit of wonder at the vision and generosity of the Parkinson family. A little over 3 years ago, we met with Bob and Betty Parkinson to talk about this innovative approach to better, more integrated, more equitable healthcare delivery. Out of that conversation, the Parkinson School was born. It is truly amazing when we consider the conversations, ideas, and projects presented today, and to think how far we have come. We are grateful to Betty for her gift to support this challenge, and I feel certain that Bob is smiling over us today. To Lyfebulb and to all our colleagues, donors, and supporters, this would not be possible without you. So thank you. And to our finalists today, best wishes. Thank you for your innovation and leadership in building more effective modes of healing and moving us toward a better world for all. So congratulations and thank you.
Thank you so much, Dr. Callahan. That was beautiful, beautiful speech. And thank you to the school, to the Parkinson family, of course. And I also want to extend my gratitude to the fantastic judges who've spent 2 days with us and assessed these incredible presentations led by amazing entrepreneurs who really have used their lived experience and the crisis that we have all faced over the past now almost 2 years, extending through the COVID pandemic. And what is remarkable is that technology that comes out of such a crisis can be converted into something that is sustainable, addressing not just a viral pandemic, but also chronic disease, both mental and physical. We've seen here technologies addressing monitoring, addressing remote monitoring, detecting prevention, but also treatment. When we see biofeedback programs, we've seen how we bring together communities, but also how we monitor with devices that are sophisticated and require FDA pathways. So yes, indeed, our judges have a difficult moment over the next hour or so to judge between these finalists. And I want to say something that I think is important, that these 11 finalists are all winners. They all come here with very different proposals, but what is unifying is that they are helping people already, and they are passionate about what they're doing. Their impact is clear, and what we're doing now is just trying to put forward 3 companies to be awarded the monetary prizes that are so generously donated to us from the Parkinson School and Loyola University of Chicago. So yes, we are moving on now to that moment. We will all take a brief break for everyone but the jury. The break is a little bit longer. The jury will gather back in about 15 minutes, and everyone else we will see at 3:45 Eastern Time for an award ceremony and winners reveal. Thank you so much to everyone. So welcome back, and we are excited to have been deliberating with the jury. It's been very, very difficult, and but we do have 3 winners, 1 winner and 2 runner-ups. So I just want to say Elaine and I are extremely excited to be co-hosting this event again, and we want to thank the teams that have worked so hard, the Loyola team, the Parkinson School team, as well as the Lyfebulb team. And I want to bring out Merle and Anna, especially, have been project managing this from the start. But now, with no further ado, I'd like to introduce again Dr. Ram Raju, who is our chairperson for the jury, to be presenting our runner-ups as well as our winner. Elaine, anything else?
No, I think we need a drum roll.
Yes.
A virtual drum roll.
Yeah, virtual drum roll. Good. So thank you, Karen. Thank you, Elaine. And, I'm not really going to kind of labor this point, but this has been a phenomenally great experience for me. And the last 2 days, I've learned a lot. And I'm all touched by your passion, your innovation, and your commitment to healthcare. All those things are absolutely fabulous. And I said in the meeting yesterday that I have a lot of faith in that our healthcare system will definitely be one day better and more equitable than it is today. So without any further ado, let me just announce the 2 runner-ups. The first runner-up is Dr. Yair Saperstein, AVO Med. The other runner-up is Mihir Shah, UE Life Sciences. And the grand winner is Dr. Catherine Grill, Newlith. So congratulations to the winners. And I also want to emphasize the point that all of you are really doing a great job. Any one of you could be winners. It has been one of the toughest jobs to select somebody out of this elite group of people. I want to close with one final observation and a request and a plea. Right? Having been in healthcare over 40 years and contributed to most of the problems in healthcare in this country, which I am personally responsible for most of the problems, right? I want to tell you, as you approach a product or whatever it is, make sure that you are taking care of vulnerable people. Vulnerable people does not mean just putting in a wearable on a black man's watch or black man's wrist or giving education to a Hispanic person. The vulnerability based on many, many factors, not only based on race and ethnicity, the other things involved. So as you hope and develop the product and you go into that, I hope you will serve the vulnerable population in this country so that we can have an equitable healthcare in this country for all. So congratulations. It has been a fabulous experience for me. So congratulations to all of you. All of you have done very, very well. And on a personal level, I told them that I'll be more than happy to be of help and guidance, advice. If I could be of, I'm more than happy to be a part of any one of you because you're all trying to improve the healthcare in this country. And thank you for that.
Wonderful. Any comments, Catherine?
Yeah, I just want to say thank you to everyone who organized this competition. We've been a part of various competitions, and this was probably by far the most well organized. And I think just really fantastic because it brought together such a diversity of entrepreneurs, but also opinions, not just the entrepreneurs, but then there's the academics and the patient advocates as well. And we really got to participate in such wonderful and rich conversations. So I'm so honored. There were so many fantastic finalists and really just honored and humbled to be here. So thank you to everyone and congrats to the rest of the finalists.
Mihir.
Super exciting. I'm going to call my kids and tell them that I won and they could be part of it. So I just sent them the link to watch on YouTube. Super exciting. Catherine, congratulations. Yair, congratulations. Would love to stay in touch. And actually, we're going to do that project in Chicago, one way or the other.
And Yair.
Echoing some of those sentiments, thank you to you guys here who are spotlighted, and really to everybody who helped put this together. And thank you to the other contestants. hearing the presentations. Catherine, especially yours, Mihir, and really everybody's. I was so impressed. And, I've reached out to some of you already to collaborate personally, but I would love to be in touch. And I think having us all together and working together in this mutual goal that we're all going towards is a good thing. And so just really wanted to say thank you and wanted to say congratulations to everyone here.
Wonderful. And I think the conversation will continue. We are going to invite the winners over to a separate Zoom room to have some interviews and further, I think, conversation with both students and journalists. The rest of you can continue with this great conversation. We are really happy that you enjoyed these 2 days, and of course all the preparation ahead of it. So we thank you, and we again thanks so much to our judges and also our ambassadors who joined yesterday and created that very engaging conversation, bringing the points that Dr. Raju made. It is not as easy as creating technology. We also need the people who may not be using the technology to be using it. So it's about advocacy, it's about reach, it's about community, in addition to technology and innovation. So thank you so much. And above, of course, thank you, Elaine, for your generous commitment to this and the prize money to our winners. Thank you so much.
If I might just add, the theme of this one was meeting the moment. And when we put that together, we were thinking of meeting the moment of COVID-19. And how do we think about building back stronger, better? How do we learn from COVID-19? And there will be other emerging infectious diseases. But I think we can close a bit, and just the learning and listening to everyone is how do we meet the moment, as Dr. Raju was saying, to keep in mind all peoples as we develop our innovation, and having all peoples at top of mind, so that as we are creating, we're meeting the moment for everyone, and that we are all contributing to the collective fabric in which we're trying to improve health and health equity for all. So it was just really inspiring to see how each of you are doing that, the energy that you bring, and it's going to be exciting to see how it unfolds. I just want to add my further words to what others have said, to thank the judges. As I reflect, you're kind, but had that radical candor in the questions that you're asking, and that's not easy to do, because it's through that kind of love and commitment to help new teams and companies get started that we can have a more, as Karin has said, a more supportive dolphin tank as opposed to a tearing down shark tank. And I just want to thank you, Karin, and your whole team. We are learning by doing as well. This is our first launch, and just like when you launch a new product, we have to understand our customer feedback. And you all, as entrepreneurs out there, are the people that we're trying to serve, and trying to think about how we as universities can provide value add to the collective entrepreneur ecosystem. So your feedback has been most valuable, and we've learned a lot just by listening to you as well. And it wouldn't be possible without the Parkinson Innovation Fund, and we're fortunate to be able to bring that fund to actually try to support the work that you all are trying to accomplish. So with that, it's with much gratitude. Thank you.